To the workshop. My name is Joe Wong. I'm a program officer at NIAAA and a co-organizer for this workshop. Before I turn the podium to Vijay, our chair, I would like to go through several housekeeping items. This is an in-person meeting with a Zoom viewing option for the attendees here. The water, coffee, and tea outside. I have sent a map and a facility and cafe and vending machine. So feel free to check into your email, or there's a copy outside. You can figure that out through that map. For speakers, if you have slides that hasn't loaded up yet, find me during the breaks. We got a really excellent AV specialist here going to help us transition. And his name is Chris. I'm sure you have saw him, work with him. For our online audience, the meeting will be recorded. Please turn off your video and audio. We recommend you use the chat box for your question and comments. And for our session chairs, Bill Dante will be in charge of the online comments and questions. Please ask him once the discussion session starts. Now, let me turn to our workshop chair, Vijay. Thank you.
Thanks, Joe. It's a pleasure to see everyone here today. Happy everyone could fight through the traffic. Yeah, we don't have this traffic in Rochester. So this is a great topic today on continued focus of integration of ALD and AUD and new ways to think about this. And so really the conference is going to focus on the research that can inform action. Yeah. And so we're really looking forward to it, and I'm grateful to all of NIAAA for supporting this. And we have a mixed audience here. We have some ASLD folks, we have folks from the government, and we have folks from our traditional academic medical centers. So it's going to be a great opportunity for interaction. So since we're running about 15 minutes late, we just put a 15-minute delay timestamp on everything, and then the lunch options here, you know, they're relatively quick, so I think we'll be able to get ourselves back in time by the afternoon. So I'm going to go ahead and introduce somebody who needs no introduction, is the boss of the building, George Koob. George, most of you know George from working here, but George for a long time has focused on neurobiology of addiction, longstanding leader of the center at Scripps Clinic, and for several years now has been heading NIAAA and has been a big proponent of AUD and also ALD. And we're grateful to him for all of his support for this integration therapies.
Well, thanks, Vijay. It's a pleasure to be here, and I'd like to welcome you to NIAAA. I don't direct the whole building. There are several institutes here, but I like the idea. Maybe we could use the whole building, especially when it comes to meeting. Anyway, so today I just want to make a few opening remarks. I think most of you are. So how do we move the cursor? I have to click on it first. There we go. So I think most of you are familiar with the pathology that's associated with alcohol misuse and alcohol use disorder. These are our latest statistics from the CDC, which is almost 180,000 people we lose each year to alcohol use disorder. You know, 30 million people in the United States we lose to alcohol. 30 million people in the United States with alcohol use disorder. And one of the most striking observations is 5 million emergency department visits per year in the United States. And, You know, I always say that if you go into any major medical center in the United States on a Friday or Saturday night, half the people there are there because of alcohol. They've either run their motorcycle into the wall, fallen off a ladder, or got in a fight in a bar. So, you know, or have some acute medical condition, like something associated with alcohol-associated liver disease or gastrointestinal bleed or something of that nature. So I'm not going to keep going on that. You also know this slide, 200 different conditions that alcohol either causes or exacerbates. Your focus, of course, is on the liver, and the liver being obviously the primary site of alcohol metabolism makes it particularly vulnerable to alcohol-related tissue injury. And again, you know, I don't have to dwell on all of this. Alcohol-associated liver disease now represents a spectrum of liver disease, including more advanced stages such as alcohol-associated hepatitis and cirrhosis. There are no FDA-approved treatments for alcohol-associated liver disease. Most ALD patients also meet the criteria for alcohol use disorder, and that's part of the theme of this meeting. And ALD is the most common alcohol-related cause of death and the leading cause of liver transplantation now in the United States. And alcohol misuse accounts for over half, or for nearly half, of the liver disease deaths each year. And mortality is 20 to 40% within 3 months of diagnosis of severe alcohol-associated hepatitis, and up to 70% for patients who do not respond to corticosteroids. So, you know, I don't have to go through much of the detail about the liver for this group. But I think it's important to realize that the number of patients associated with alcohol-associated liver disease who are listed for liver transplants increased 63% between 2007 and 2017. And there's been a steady increase in alcohol-associated liver disease related deaths between 2000 and 2019. And the other part that you can see from the graph on this slide is that ALD is now passing non-ALD deaths in the last 3 or 4 years of these data. And the other part that's been in the news a lot lately is rates are increasing faster for women and among young adults. And people are talking about young adults getting liver transplants at some of the major transplant centers in the United States because of alcohol-associated liver disease. So we believe this workshop is timely. There are ongoing challenges for the prevention of and early intervention of alcohol-associated liver disease. Early stage liver dysfunction is also, it is often asymptomatic and rarely recognized in the clinic. Symptomatic patients with ALD entering the emergency room or the liver clinic are often already in late stage when liver transplant is the only treatment option. However, recent research and clinical advances paved the way for progress. Advances in non-invasive tools can now assess fibrosis, a prognostic predictor for severe alcohol-associated liver disease, an area we've been supporting for some time in research. There's an increasing interest in an application of integrated care, something that's come on the scene very recently, but we're very enthusiastic about at NIAAA. And there is now a wider acceptance of alcohol use screening and brief intervention in primary care and other settings. And this is one of our biggest dreams. We are seeing a pretty good uptake of screening in primary care and health clinics, but what we're not seeing is brief intervention or any referral to treatment, almost less than 5%. So these are big issues. I think you'll be talking about some of them today. I will be here as much as I can today with a couple other obligations that come up. I want to thank the organizers of the workshop who are listed here on the left-hand side. And for my slides, a special thanks to Laura Rockaway Lenardi, Laura Manella, and Bridget Williams Simmons. I hope you all are aware that we have a great website. It's a living document. It's upgraded all the time, and any statistics you ever hear me or our staff present, you can find on our website on the front page. So if you go into the website, click on NIAAA, that's all you have to do. Just click on NIAAA and scroll down. There'll be a little box that says facts and statistics. It's my favorite part of the website. If you find errors, let us know because we'll fix them. So thank you very much and have a great meeting.
Thanks, George.
Kathy, just for everyone here, I'll be setting up a timer on my cell phone so we can keep track of the time. Thank you.
Thanks, Joe. So welcome to session one. I am one of the chairs of session one and also one of the speakers. You see here a summary of what will occur in the session. You see the speakers and their titles listed. I won't go through them all right now because I'll be giving introductions to the talks as the people give their talks. Just to let you know that this is what you're up for now. It's an introduction. It's going to set the stage for the rest of the meeting. So I am the first speaker. My name is Kathy Young. I'm the director of the Division of Metabolism and Health Effects in NIAAA. And I'm going to talk about the scope and the objectives of the meeting. So as Dr. Koob just stated very clearly, alcohol-associated liver disease accounts for a major proportion of liver disease burden in the U.S. There are other etiologies of liver disease, but our focus here, of course, is on alcohol-associated liver disease and AUD. We're going to hear a great deal, because not all of us are hepatologists in the audience, so we're going to hear in great detail more about liver disease, the stages of it, the presentation, natural history, and so on. And I think that will help to give us a background to really understand why we need to reduce the burden thereof. So what I'm going to do next is tell you that sometimes it makes sense to state the obvious, and that's what I'm going to do right now. So what I want to say is that liver disease is a progression. It goes in stages. They can be the earliest stages are asymptomatic or have mild symptoms, and those are unrecognized, undetected mainly. Then as it goes on to more serious stages, which Doug is going to tell us about and others will tell you about, it becomes very serious and largely irreversible. And there are no effective pharmacological treatments. There are no FDA-approved treatments for alcohol-associated liver disease. While I'm speaking, I will go back and forth between saying alcohol-associated liver disease or ALD. I'll use the terms interchangeably. Also, by the way, throughout the session and throughout the meeting, alcohol use disorder will be abbreviated AUD, just so we all know what we're talking about. We'll try to remind people what it is. I think most people in this room know both of those, of course. Because in the end stage of liver disease, the only possible treatment is transplantation, and that's not widely available for a number of reasons, not enough donor livers, and there are many factors about whether or not someone will actually even qualify to be recommended for liver transplant. So we know very well now that alcohol use disorder and alcohol-associated liver disease are comorbid conditions, and that successful treatment must address both of those conditions. There's mounting evidence that elimination of alcohol exposure improves the outcome of liver disease early on and even later on, even when someone is cirrhotic. More in the more spirit of this session, I want to, and that is prevention and reducing the burden. There's evidence that treating AUD helps to reduce the incidence, the onset of ALD, and also progression from early stage to the more serious stages. And also interesting, recent data suggests that screening for ALD can help reduce AUD. That was from Maya Thiele's group. So this is a session is about burden. It's clear that advanced ALD imposes a burden on the patient, loss of quality of life, a burden on the family, emotional and financial stress, and a burden on the healthcare system. Because the burden on the healthcare system is long hospital stays, repeated hospitalization, and the expense. So we want to reduce the burden by preventing ALD and preventing the progression of ALD to more serious stages. Again, I'm stating the obvious, but this underlies why we're here, why we're all here. So what if alcohol-associated liver disease could be prevented and alcohol misuse could be screened, diagnosed, and mitigated? As in any clinical condition, it makes sense to prevent disease altogether or to intervene at early stages to prevent the progression to more serious stages. Since there's no good widely available treatment for reversing advanced disease, it makes sense to devote energy and time to intervening in the earliest stages when it's still possible to prevent the progression. So how do we do this? What is needed? Population-wide screening is the ideal, but we have to start with actionable steps. So we propose to start with targeted populations, including identifying at-risk individuals. Detecting earliest stages of ALD, including asymptomatic and at-risk, will be addressed in this session by Tiffany Wu and in session 3. Screening tools. There are screening tools for both disorders, for AUD and ALD. They're different for each disorder, of course, and you'll hear about those tools and protocols in sessions 2 and 3. Linkage to treatment is going to be necessary, and I want to note that partnerships between addiction specialists and hepatologists already exist, mostly in tertiary care and not often enough, all too rarely. Thankfully, this workshop is a good example of hepatologists and addiction care specialists working together to move things forward. You'll hear more about the partnerships throughout the workshop, actually, but especially in session 4. And it's important to remind ourselves that the goal to expand screening and referral to primary care level, and as Dr. Koop said, more to the point, referral to treatment and treatment at the primary care level. So we hope to stimulate the discussion about real-world challenges in primary care and specialty care during this talk. We will hear from 2 clinicians this morning in the early session about their day-to-day experiences with AUD and ALD. And later, a full session that explores the real-world issue fuller. I want to emphasize that these insights from the providers themselves will be invaluable. This is the kind of information we need to hear, so we know where the challenges are and how to break them down. So what are the steps forward to prevent ALD, to reduce the burden? As we point out, a significant challenge at the early stage is the need to identify and engage with patients, but diseases are not commonly recognized early on. So as stated before, we want to use the resources wisely, and perhaps the plan is to select targeted populations. We'll hear about likely populations and identifying at-risk populations in session 1 and in session 3. So there are good current tools for screening and diagnosis of AUD that are well validated. And you'll see that in session 2. The question we have to answer is, how do we implement them? Brief intervention, referral to treatment across settings, and how will we achieve that? The strategies for early detection of ALD include non-invasive imaging techniques and dedicated blood tests. You'll hear the discussion of these with pros and cons in session 3. Again, how to set up the necessary infrastructure for detection of ALD in diverse, under-resourced areas is one of the challenges that remain to be determined. And infrastructure can be personnel, equipment, tools, knowing how to do that. Regarding integration of care, the field now understands that caring for patients with more advanced ALD is best when both mental health professionals and hepatologists take part in the patient care. And the goal of integrated care is possible. There are examples of the establishment at the tertiary care level where multidisciplinary clinics, bringing together the 2 disciplines in close proximity, take care of patients. So Jessica Mellinger and her colleagues are the early pioneers in this, and have kind of set the tone and set the stage for this. The University of Wisconsin and a few other places now also have established integrated care clinics that are working. The question, how to implement integration of liver and addiction care in primary care, remains the challenge. Section 5 will address the real-world concerns and experiences. We really look forward to, again, the useful insights that will come from that information. Finally, what would success look like? The recommendations from this workshop should have practical value. There should be ways to test for the success or failure of the steps taken, of the actions put into place. We look forward to useful insights. And throughout, I want to emphasize that we are keeping in mind underserved, rural, and vulnerable populations. So, about the scope of this meeting. The workshop brings together experts in distinct disciplines, the hepatologists who are experts in management of liver disease, experts in clinical practice of addiction medicine, and not to be left out, experts in healthcare delivery, in implementation to wider settings and in outcome assessment. All these groups are hence essential to working together as a team to get complete and effective prevention of ALD. In fact, to how to achieve the prevention of ALD, what the optimal recommendations will be arrived at by the end of this session, by the end of this meeting, not this session. So the intention of the workshop is to generate this conversation between all these multidisciplinary people about clinical practice, screening, detecting, managing alcohol use, managing alcohol-associated liver disease, and identifying unmet research needs and opportunities. We'll explore barriers to early detection and intervention, identify necessary improvements in protocols and tools, and hopefully recommend a clear path forward. Just a quick reminder, NIH does not set policy. Rather, we organize workshops that bring the experts together to talk about and inform the relevant areas of human health. Our primary function is to fund research. Research creates, we hope, ends up with evidence, and evidence is used to advise clinical practice, to inform, not to advise, to inform the people who write the guidelines, the entities who do the guidelines for medical care, and entities, perhaps policymaking bodies. We provide the evidence. So that's pretty much all I have to say with one more thing, and that is I want you to be introduced to the entire organizing committee of this group. As you see, Vijay Shah up in the left corner and Joe Wong in the lower right corner are the true co-chairs of the whole session. And you'll also see Sumit Asrani from Baylor University, Jessica Mellinger from the University of Michigan, Stacy Sterling from Kaiser Permanente, and in the bottom row, a few more NIAAA folks. Laura Kwakow of the Division of Treatment and Recovery, myself, and Svetlana Radayeva, who's Deputy Director of the Division of Metabolism and Health Effects. So that is the end of my talk, and now let's go on to some real talks. Yeah, Doug, please. Chris, while Chris is setting up the slides, I do want to tell you that we all made a executive decision early on not to make the personal introductions too long, rather to give the time to the speakers for the interesting content. So I will tell you about Doug Simonetto. He's an associate professor of medicine and a transplant hepatologist at the Mayo Clinic in Rochester. He serves as the director of the Gastroenterology and Hepatology Fellowship Program. His research focuses on outcomes and management of alcohol-associated liver disease, and it spans from clinical trials to advanced data analytics and digital interventions. Thanks, Doug.
Thank you, Kathy. And thank you to organizers for the opportunity to be a part of this workshop. So as we have a diverse group of folks in the audience with different areas of expertise and background, I was tasked to cover the background and overview of ALD burden from natural history to management. First, I'd like to start just by highlighting the preferred terminology and non-stigmatized terminology that we should be using when referring to these conditions. Really should stay away from using the term alcoholic any longer, which is quite stigmatizing for our patients. Also, some basic definitions for heavy alcohol use, just as a reminder, that refers to more than 3 drinks per day for women or 4 drinks per day for men. Binge drinking being defined as more than 4 to 5 drinks within 2 hours for women and men, respectively. And also to mention that in the US, we do have some of the highest considered low risk limits for alcohol use compared to other countries in the world. And the relationship between alcohol consumption and cirrhosis may in fact tell us that even lower amounts of alcohol use can potentially be harmful. So this is a systematic review that tried to address this question, the relationship between alcohol consumption and the risk of cirrhosis. So this study included 9 studies over the span of 30 years. And you can see here on the graphs that the relationship between alcohol consumption and risk of cirrhosis is quite linear. Unfortunately, on the left, you can see that this relationship for men, we were not able to identify a specific threshold for what's considered high-risk drinking for risk of cirrhosis, and that's because of the quite wide confidence interval you can appreciate there, but you can appreciate the linear relationship. For women, on the other hand, it appears that even one drink a day is sufficient to increase the risk of cirrhosis, with a relative risk of 1.64, and that was significant. You can also appreciate that the line is steeper for women compared to men. So maybe the thresholds for heavy alcohol consumption or safe alcohol use are lower than we have anticipated. So how does alcohol lead to liver injury? There are two main mechanisms. So alcohol has a direct impact on the liver by promoting oxidative stress and mitochondrial injury, which in turn will lead to death of liver cells and hepatocytes and release of intracellular compounds or DAMPs, damage-associated molecular patterns, which in turn activate the immune system, leading to more further cell death and liver failure. Alcohol also has an effect in the gut by promoting and increasing the qualitative, leading to qualitative and quantitative changes in the microbiome, and also increasing gut permeability, so allowing translocation of bacterial products, or PAMPs, pathogen-associated molecular patterns, which lead to further activation of the immune system and consequently further cell death and liver injury. Over time, with ongoing chronic liver injury, the liver has decreasing capacity to regenerate, and in turn, the dead liver cells become replaced by collagen, scar tissue, or fibrosis. And over time, over the course of many years, this will lead to cirrhosis. So with regard to the spectrum of ALD or natural history of ALD, first stage is bland steatosis. In fact, 90% of us, after a binge drinking episode or heavy alcohol use, will develop some fat in the liver. This may happen in a matter of days, but it is reversible as long as the alcohol use is not continued at a high level. If it is, up to 20 to 40% of us will develop fibrosis and inflammation. And again, if that continues over time, and this does not happen fast, this is over the course of many years or even decades, 10 to 20% of individuals will develop cirrhosis. About a third of patients with ALD will present with acute alcohol-associated hepatitis, or ALCHAP, which is an acute form of ALD, and these patients typically present with jaundice and acutely ill, and unfortunately, these patients have a very high mortality, up to 30% within 90 days. And you may be wondering why 10 to 20% of patients with severe ALD only develop cirrhosis. We do know that there are other risk factors for cirrhosis, some of them listed here, including obesity, genetics, and female sex, and likely there are many others that are still unknown. With regard to the clinical presentations of ALD, unfortunately, most of our patients, as was mentioned before by Kathy, remain asymptomatic. For the largest duration of the disease, they don't have any symptoms or complications of their liver disease. And that goes from the steatosis phase all the way to cirrhosis. So even patients with cirrhosis may remain asymptomatic for up to 10 to 12 years until they actually decompensate. And decompensation being defined by the development of ascites, variceal bleeding, hepatic encephalopathy, or potentially jaundice. And as I mentioned before, about a third of patients will present with the acute form of ALD, ALCHAP. These patients will present with jaundice and have a very high mortality. Unfortunately, prognosis of patients with ALCHAP and decompensated ALD cirrhosis is very poor. So I'm going to show you some data and some numbers to highlight the rise in this problem and some data about management. So first is the study from Dr. Malinger and colleagues, where they looked at a national cohort of patients with private insurance. And you can see on the left that the prevalence of alcohol-associated cirrhosis increased for both men and women in just over the course of 6 years, from 2009 and 2015. And on the right, you can see that patients that have alcohol-related cirrhosis were more likely to be decompensated when they first presented. Up to a third of them already had decompensated cirrhosis when they were diagnosed with ALD, as opposed to 10% of patients with cirrhosis from other causes. And as expected, the cost was higher, almost doubled per person cost for the first year after diagnosis, and that's likely because of the healthcare utilization, since these patients had more advanced stages of liver disease. Similarly, ALCHAP is also on the rise. So this is a population study from Olmsted County in Minnesota. We looked at the incidence of ALCHAP over the span of almost 20 years, from 2000 to 2018. And you can see by the middle solid line that the incidence of ALCHAP has more than doubled over the span of 20 years. But more significantly, if you look at the dotted line at the bottom, that represents the incidence of ALCHAP for women, and that increased by 7-fold during the same time period. And unfortunately, mortality is also on the rise, and this was mentioned before by George. This is data from the NIAAA, and you can see the red dotted line represents mortality from alcohol-associated cirrhosis, which was mentioned before, it increased by nearly 50% over the span of about 20 years, and is compared to other causes of cirrhosis noted here. This increase was more pronounced in women, not shown here. The mortality related to alcohol-associated cirrhosis for women increased by 83% compared to 33% for men. So the mortality is proportionally increased for women. Similarly, mortality is also increasing for young adults, as also mentioned before. So this graph represents the proportion of cirrhosis-related deaths attributed to alcohol. The top two lines represent young adults ages 25 to 44. And you can see that as of 2019, 75 to over 80% of all cirrhosis-related deaths in young adults were due to alcohol. And that number has significantly increased over the past 20 years as well. Dr. Singhal and colleagues have shown that hospitalizations for ALD and ALCHAP are also on the rise, and disproportionately so in young adults. So first, they just reported the percentage of the population with harmful alcohol use as previously defined. And you can see that young adults less than 35 years of age, about a third of them reported harmful alcohol use, and about half of them reported binge drinking. And that was significantly higher than older adults. Now on the right, you see the hospitalization rates for ALD on the left and ALCHAP on the right. This was done using the national inpatient sample data as by age group. So I'm sorry for the busy graph here, but I'll call your attention to the black bars at the bottom. They represent the young patients younger than 35 years of age. And you can see that the proportion of hospitalizations significantly increased from 2006 to 2016 for ALD on the left and for ALCHAP on the right. For ALCHAP, you can see that the proportion more than doubled from 8% in 2006 to 18% in 2016. Now, as also alluded before, ALD, unfortunately, is often diagnosed at late stages when patients already have decompensated disease or ALCHAP. So this is a multi-center study from 17 countries and 5 continents where they explored the presentation of patients with different etiologies of liver disease. And strikingly, you can see here on the left, the top 2 bars are patients with ALD, where 90% of them presented with late stages of disease, defined as decompensated cirrhosis. And only about 11% of them were diagnosed with liver disease in earlier stages, defined as pre-cirrhotic. And that is in contrast to other causes of liver disease, such as hepatitis C, hepatitis B, and MASLD, shown in this graph. On the right is the odds ratio for the risk of presenting in late stages of disease or decompensated, which was 14. So patients with ALD had 14 greater odds of presenting with late stages of disease compared to hepatitis C, which was used for a reference here. And again, that is strikingly and quite a significant difference from other causes of liver disease. Now, liver-directed therapies, unfortunately, are limited. Unfortunately, all we have is prednisolone for a subset of patients with severe ALCHAP. And prednisolone really only benefits patients in terms of short-term 28-day survival and is associated with double the risk of infections. And we really don't have any other drug therapies that can target a liver injury and liver disease. Short of that, liver transplantation is the ultimate treatment for patients with advanced late stages of liver disease, decompensated cirrhosis or ALCHAP. And in fact, transplantation for ALD is rising. So this is data from SRTR. The blue bars represent the number of transplants in the US from 1995 to 2022 for ALD. And the smaller red bars here you see on the right represent the number of liver transplants for ALCHAP. And you can see that both are increasing, especially over the past 10 years. And although the number of liver transplants in the US is increasing, organs are still scarce and expensive resource and only benefit a subset of patients. What we do know is that AUD treatment has a benefit. It can change outcomes, and that's the purpose of this meeting. So this is a study from our group looking at the impact of AUD treatment on patients recently hospitalized for ALCAP. We had 2 cohorts from Mayo and VCU, and we found that patients that underwent early AUD treatment within 30 days of hospital discharge were significantly less likely to relapse to drinking within 30 days, from 45% those that did not attend AUD treatment down to 5 to 7% on those that did attend AUD treatment. More importantly, long-term survival was better in those that attended early alcohol rehab compared to those that did not, represented by the blue lines here and the red lines respectively. However, alcohol abstinence leads to even better outcomes if it's achieved earlier or in earlier stages of ALD. So this is a study from Austria where they had 2 cohort of patients, one with compensated ALD cirrhosis, one with decompensated. As expected, you can see the abstinence led to improved survival in both cohorts. But if you pay attention to the top dotted line on both graphs, those that achieved abstinence while they were still compensated, 10-year survival was about 95% compared to about 60% on those that achieved abstinence after they already had decompensated disease. So achieving abstinence helps in both early stages and late stages of disease, but if we can achieve that earlier, we will have better long-term outcomes. Similarly, AUD treatment also leads or is associated with decreased risk of decompensation or progression of liver disease in those that have compensated disease. So this is a study from the VA with over 35,000 patients with AUD and compensated cirrhosis, and they found about a 40% reduction on the risk of decompensation within 6 months for patients that underwent any AUD treatment. That includes pharmacotherapy or behavioral therapy or both. And similarly, they also found a significant benefit on survival, both short-term, 6 months, and long-term. And if you're not convinced yet, another study, this from MGH, focusing just on pharmacotherapy for AUD, so just drug therapy. And they also found that those that received drug treatment for the AUD had significantly lower risk of decompensation in those that had compensated alcohol-associated cirrhosis. So on the left, you have the Kaplan-Meier curve showing that those that underwent treatment had a 25% odds of decompensating at 10 years compared to over 60% for those that did not receive any AUD treatment. And the mean time to decompensation was only 2 years for those untreated and over 6 years for those that underwent or received AUD pharmacotherapy. So in summary, what I discussed today, so the prevalence of ALD and cirrhosis-related mortality are rising, disproportionately so in women and young adults. ALD, unfortunately, is mostly diagnosed in late stages of disease compared to other causes of liver disease. We have limited options for liver-directed therapies for both ALD and ALCAP, but we do know that early AUD interventions lead to better long-term outcomes. Thank you.
Thanks, Doug. So our next speaker is Dr. Tiffany Wu, and she's currently a transplant hepatology fellow at the Mayo Clinic in Rochester. During her fellowship, she's established save time. You can save time. She established a clinical and research focus in using digital solutions to manage patients at the intersection of alcohol-associated liver disease and alcohol use disorder. She is interested in the development specifically of digital biomarkers of behavior to understand disease susceptibility and progression and to inform delivery of personalized care. Tiffany.
Oh, sorry. Thank you, Dr. Young, for the kind introduction. Thank you to the NIAAA and the workshop organizers and to everyone in this room, both in person and virtually, for the opportunity to present the characteristics of populations with asymptomatic ALD. In the next 20 minutes, what I aim to achieve is to identify characteristics of unique patient populations at high risk for developing ALD, to develop a framework for approaching screening and early detection of ALD, and to identify cost-effective tools and strategies for prioritization and engagement of target populations. As Dr. Simonetto covered in the previous session, alcohol-associated liver disease is frequently detected at advanced stages of liver disease when individuals will present with decompensations from cirrhosis or acute alcohol-associated hepatitis. This does lead to increased hospitalizations, higher healthcare costs, and worse patient outcomes. Multiple challenges exist for the early detection of ALD. This includes a varied understanding of alcohol use disorder and alcohol misuse across providers of different disciplines. Furthermore, definitions have evolved relating to alcohol use disorder and alcohol misuse. In the transition from DSM-4 to DSM-5 criteria, DSM-5 criteria seems to magnify AUD prevalence. From the practical standpoint, DSM-5 criteria and ICD-10 codes converge well for severe AUD, but do not adequately capture mild or moderate disease. Other risk factors in the setting of heavy drinking may also be associated with alcohol-associated liver disease, such as heavy drinking in the setting of a prior Roux-en-Y gastric bypass. The United States Preventive Services Task Force does recommend universal screening for alcohol misuse among all adults in the primary care setting. However, we do need robust infrastructure for standardizing and implementing this practice. These challenges culminate in a critical gap in our understanding of which individuals with heavy drinking will develop severe liver disease. How do we fill this gap? The desired solution is the ability to detect early asymptomatic ALD. Therefore, we aim to identify populations at risk for developing ALD and to develop a framework for cost-effective screening for identification of asymptomatic ALD. To begin with a definition of populations with AUD, we have seen in the United States all categories of heavy drinking increasing over time. Data from the National Epidemiological Survey for Alcohol and Related Conditions, or the NIAAA, has estimated an AUD prevalence of over 12% as of 2012. The table on the right provides a breakdown of sociodemographic characteristics in this patient population in 2012, with the rightmost column demonstrating the percent change over the prior 10 years. Overall, the greatest increases were seen among women, racial and ethnic minorities, including Black individuals, Asian and Pacific Islanders, and Hispanics, and adults 65 years and greater. These, along with other sociodemographic characteristics, may all play a role. Now, in looking at the ALD population, we have also seen sampling from the National Health and Nutritional Examination Survey that has looked at trends of ALD over time. And in the graph, we have the distribution or trends of patients who have alcohol-associated fatty liver disease and those with fibrosis staging. We can see from this top line that patients with alcohol-associated fatty liver disease have generally stayed stable over the period of 2001 to 2015. However, those who have stage 2 or greater fibrosis have had a general increase over time. And by 2015, this prevalence estimated 4.7% of those with alcohol-associated fatty liver disease, 1.5% with stage 2 or greater fibrosis, and 0.2% with stage 3 or greater fibrosis. The table on the right provides a breakdown of the sociodemographic characteristics for patients who have fatty liver disease as well as stage 2 or greater fibrosis in 2015. And generally speaking, there were greater proportion of males who had alcohol-associated fatty liver disease and stage 2 fibrosis. However, the age tended to be younger in those with earlier stage of disease at age 20 to 44, and then slightly higher in the 45 to 64 age group. Among race and ethnicity, we did see that Hispanic populations had higher prevalence in both groups. Now, we've seen the ability to characterize patients with AUD and those with some degree of symptomatic ALD. Can we identify earlier asymptomatic ALD? And a challenge that we face is that, unfortunately, we lack population-based data to really assess the incidence of ALD in a population over time. So another way to frame this issue would be to ask, can we identify at-risk populations for ALD in order to target screening? Various studies have been able to identify known populations at risk for worse outcomes related to ALD. I'll provide a high-level overview that I know we will discuss and dive into further during this workshop. First is among females. In females, there is a smaller distribution of volume and altered metabolism, along with genetic polymorphisms that can affect disease progression. Furthermore, females face psychosocial and cultural treatment barriers to receiving AUD treatment. And this has resulted in an increased global prevalence of alcohol-associated cirrhosis and cancer, a higher risk and inpatient mortality for developing acute on chronic liver failure from liver disease, and a greater overall ALD-related mortality. In younger adults, there is a higher risk of harmful drinking and an overlap in metabolic syndrome. And these, along with other factors, have contributed to a greater than twofold increase in hospitalizations for ALD, along with an increase in development of acute on chronic liver failure, increased listing for liver transplant, and a higher rate of post-transplant mortality, especially among young women. Among racial minorities, there are genetic polymorphisms and structural and social determinants of health that can impact disease progression. This has led to an increase in risk of developing ALD and ACLF, or acute on chronic liver failure, among Hispanics, as well as an increased prevalence of developing acute or alcohol-associated hepatitis in Black individuals compared to whites, and then also an increase in inpatient mortality for alcohol-associated hepatitis among Native Americans and Asians compared to whites. Finally, in rural populations who face structural and social determinants of health, we have an increase in rate of ED or emergency department visits, with the less likelihood that patients can receive mental health and addiction services post-discharge. And this has led to an identification of higher post-discharge mortality. So if we can identify and isolate these at-risk groups, perhaps we can then make a diagnosis of ALD. But this challenge may be a bit harder than we can anticipate, because the identification of early asymptomatic ALD would be engaging with and being able to identify strategies to find these at-risk populations in points of care. Therefore, another way to look at this is whether or not we can identify heavy drinkers with or without AUD who may be able to target in the screening approach. Now, we do know that patients with severe AUD who are often treatment seeking will develop a chronic and relapsing course. And overall, we know that treatment utilization rates are low. Therefore, we may be missing a large subset of populations with early ALD. Furthermore, we also know that not all patients who have AUD will develop liver disease. Therefore, being able to find necessary targets and ways to prioritize these target populations is of critical importance. So this direction becomes a bit more complex than we would think. We would therefore propose the ability to identify patients through health utilization mechanisms and through an approach that actually identifies patients who are treatment seeking and treatment non-seeking. To go into the group of patients who are heavy drinkers who are not actively seeking AUD treatment. Outside of the care system may be a harder system in order to penetrate due to the need to engage in community conversations and to be able to implement large-scale public policy. But within care systems, we may have the ability to identify patients who have alcohol-related conditions. In emergency departments or EDs, this may be a ready point of contact. Data from the National Emergency Department sample has shown that rates of ED visits in 2014 had an estimated greater than 2-to-1 ratio of male to female visits. And in the age group of 45 to 54 years, this had the highest rate of visits, with the distribution seen on the upper right graph. Over time, alcohol-related visits also increased by over 61%, with an annual percent change that was greater among females compared to males between the time period of 2006 to 2014. And this was in spite of a less than 2% increase in per capita alcohol consumption. This is demonstrated in the bottom graph and may suggest that this increase in ED-related visits may not have been necessarily related to an increase in overall alcohol sales over time. Data from the same sample showed that alcohol-associated hepatitis visits had increased over time as well, from an estimate of 85 per 100,000 visits to 106 per 100,000 visits between 2016 and 2019. The highest rate of visits were among individuals aged 45 to 64. However, the rate increased the most for a younger subset of age 25 to 44. And also the severity of disease at the time of presentation has increased over time. In the hospital setting, data from the national inpatient sample has shown that AUD-related hospitalizations have increased over time by an estimate of 3.5% between 1998 to 2016 from one study. Hospitalizations for alcohol-associated hepatitis have also increased over time from 2015 to 2019, with an average age of 48, predominant males, predominant white individuals, and an average length of stay of 6 days. In a Danish study that had followed patients who were initially seen and hospitalized for alcohol-related conditions showed that both age and alcohol diagnosis were both significant predictors of cirrhosis development. And in this study, the highest predictor or highest risk was among males aged 40 to 49 over 15 years at 9.8%. In the UK, patients with alcohol-related cirrhosis who used primary and secondary health services, they were found to have used these services more frequently in years leading up to the diagnosis. And when further examining the referrals that came from primary to secondary care, they found that 64% of these patients who were referred to specialty care did not have advanced fibrosis at that time. But those who were more likely to have advanced fibrosis included men drinking over 50 units and women drinking over 35 units per week. We may also have another opportunity to engage with patient populations who have non-liver alcohol-related complications of disease. And in a study that examined the clinical coexistence of ALD with a condition called alcohol-related pancreatitis, we've been able to identify that nearly a third of patients with acute alcohol-related pancreatitis had coexisting ALD. And this was greater among patients aged 35 to 65, white individuals, and males. At the time of pancreatitis diagnosis, this study also identified that nearly a quarter of these patients had cirrhosis. In the same study, nearly 15% of patients with AUD were found to have ALD, and this was greater among those aged 50 to 65, white individuals, and males. Interestingly, on sensitivity analysis, the duration of contact had little impact on the prevalence of ALD, and ALD was suggested to be diagnosed at the time of initial presentation. This was in contrast to alcohol-associated pancreatitis prevalence that seemed to increase with the duration of contact. And now the authors of this study supposed that potentially this was related to the need for clinical characteristics in the diagnosis of pancreatitis as opposed to liver disease. Going into the subset of patients with heavy drinking who are currently in and actively seeking AUD treatment outside of the care systems, such as within Alcohol Anonymous or digital therapeutic companies, is largely unknown due to the fact that there are disparate data sets as well as private data sets that cannot be penetrated. However, within the care system for AUD treatment, we have been able to see through the National Survey on Drug Use and Health that only 1.5% of patients received substance use disorder treatment in 2021. Certainly, this may have been related to the impacts from the COVID-19 pandemic, but this was very low, and we have a distribution of characteristics as seen on the slide. In an Icelandic study that compared patients with ALD and AUD in treatment, this study found that lifetime total alcohol consumption between the two groups was similar, and that females with ALD had a significantly lower number of drinking days compared to males with ALD. In a recent study out of Canada with an investigator group led by Dr. Friesen et al., they were able to examine alcohol-related hospitalizations in the provinces of Manitoba and Ontario. The investigator group looked at all alcohol-related hospitalizations between the time period of January 1st, 2017 to December 31st, 2018. And they were able to use latent class analysis in order to develop subgroups of these patient populations that were based on the presenting initial diagnosis related to alcohol, comorbidities, as well as healthcare utilization. In looking closer at the Ontario subgrouping, they were able to identify 7 different subgroups or classes of these individuals. And you'll see that from subgroups 1 to 5, most of these were differentiated based on the alcohol-related diagnosis, with subgroup number 5 specifically being ALD, with high frequency of prior alcohol-related health service use. Subgroups 6 and 7 looked specifically more at the high frequency of all types of alcohol-related health service use across all settings in group 6, and then more primarily in the inpatient setting with ED visits and hospitalizations in subgroup 7. When the authors looked at outcomes related to these subgroups, specifically related to mortality in hospital and upon post-discharge, they looked at the fact that over time, the highest mortality hazard occurred among those with ALD in that subgroup number 5. They also looked at the incidence of readmission within 1 year of the index hospitalization. And interestingly, from the mortality hazard, the second highest group were individuals who had frequent use of hospital-based healthcare utilization. And that second line was actually higher on the incidence of readmission, suggesting that perhaps by targeting these groups who have frequent healthcare utilization, not only can you improve mortality over time, but you can also improve and reduce healthcare utilization and costs. Therefore, we can propose a schematic or a structure in order to identify who to screen for asymptomatic ALD. Along the x-axis is going to be the care setting with the negative side showing out of care and positive side showing in care. And then along the y-axis is healthcare utilization high to low. Starting in the upper left quadrant, we can propose that we see out of care treatment seeking individuals, such as through AA or private digital therapeutics as a way to target and engage in two-way conversations with our community partners. In the in-care or treatment-seeking group, we may be able to identify those patients through EDs, hospital-related settings, and primary care using alcohol-related diagnoses in order to identify and engage with these patients. In the out-of-care non-treatment seeking, this may be tougher to penetrate given that we may need to, on a larger public policy scale, be able to engage with businesses who are licensed to sell alcohol, as well as sober support groups that are in the community. And finally, in the in-care non-treatment seeking, which we know overall treatment utilization rates are low, we see that we may be able to find ways and mechanisms to engage with patients who are enrolled in detox and rehabilitation facilities or both inpatient and outpatient services for treatment. Now, certainly the care setting may dictate the way that we engage and screen. So in the out of care setting, this may be an ability to refer for testing. And in the in-care setting would be the ability to identify liver tests or to calculate FIB-4 scores and fibroscans as non-invasive measures of fibrosis. We may propose that starting in the upper right quadrant where we can identify these patients in the in-care treatment seeking phase would be a starting point. So in summary, cost-effective strategies are needed to screen and identify early asymptomatic ALD. Demographic groups at risk for developing ALD include women, young adults, racial minorities, and rural populations. An approach to identifying high-risk individuals may be targeting screening for those with that high utilization of healthcare in the care setting, with a suggested target being EDs and hospitals for alcohol-related pancreatitis, for instance. And this would enable us to have the appropriate linkage to care that has been linked to better outcomes. Finally, there are many opportunities for research given the fact that we still have a lot of missing understanding in this knowledge, such as using population-based health administrative data to capture the epidemiology of these silent populations, whether using alcohol-related health service codes or diagnosis, looking at alcohol-related complications, or the encounters themselves as procedural codes in the outpatient clinic. And finally, we can use machine learning or other advanced techniques to cluster patient populations to determine ALD risk. Thank you so much for your attention.
Thank you, Tiffany. I have a question for our next speaker. Super. So now we're going to hear from two clinicians, one in primary care and one in addiction treatment care. But these guys are in a little more of a rarefied situation than in some situations. So our speaker is Jeffrey Sohar. He's a practicing internal medicine and pediatrics physician who's committed to caring for underserved populations, both internationally and locally. He's worked in multiple clinical settings, including Botswana, Africa, caring for children and families with HIV/AIDS. He spent the last 10 years in Baylor, Scott, and White Health as the medical director for the BSWH Community Care Clinics. These are 7 clinics across North Texas that are dedicated to serving uninsured, low-income patients. Each clinic provides access to care with embedded integrated care teams with the purpose of improving long-term outcomes by managing medical concerns and addressing social determinants of health. Dr. Zohar.
Thank you. Thanks to our organizers. This is quite an opportunity to speak to everyone on a global scale, a little bit different than what we've heard before on what's the primary care perspective on alcohol use disorder, and how can we work in that space. So that's what I hope to talk to today is the different perspective of what we see. So this is the USPSTF framework for screening adolescents and adults for unhealthy alcohol use, and then brief intervention and referral for treatment those are the recommendations. That's what we're told to do. But then we encounter, what are the barriers? What are the things that make this a challenge? So let me speak a little bit about these before we talk about maybe how we can address it. Time, subjective screening, our patients' attitudes towards alcohol. These are all things that come up very frequently. And then we consider the other comorbidities that will come with alcoholic liver disease or alcoholic use disorder. This is not well reimbursed, which is a disincentive for a lot of people in the time that they have to do. And then the access to these interventions and referring to specialists, while maybe ideal, is not always the realistic approach that we can take to addressing some of these needs. So just to start with, what are the responsibilities of a primary care doctor? There are many, as you all know. We start with maybe 20 or more patients a day, and that gives us 10 to 20 minutes a patient. Then the question is, well, when do you screen? And what's the right time to intervene? And how do you approach this? Do we do it when they come in because they have pneumonia? Do we do it when they are here for preventive care? And what is the time allotment that we can give to a patient as we're doing preventive screening? So we look at the cardiovascular risk and cancer risk, STDs and bloodborne infections and psychological health, of which of those screenings, alcohol use disorder is one of those, and vaccination. So there are a few things that we're thinking about as we look at how do we address this with our populations. And then within EPIC, there's the Audit C, which we're all very familiar with. And we may go through this, but that raises the question of, okay, well, what do we do with this now? We recognize as primary care doctors, as doctors in general, that our patients are underreporting how much alcohol they're drinking. The alcohol consumption in the US public health surveys only covers 30 to 60% of per capita alcohol sales. So the number of multiply whatever they're telling you by 2 or 3 is validated in literature. And then a lot of times our patients don't want to talk about it or don't have an understanding of the impact of alcohol use disorder. But one of the studies that I did see said that when a patient is established and satisfied with their primary care doctor, they're much more likely to have a positive attitude towards screening and then a brief intervention. So this is pointing us towards the screening certainly, but also acting in this space really needs to be in primary care, at least as a start. And then other things that are complicating all of this are the social determinants of health that we well know as well. We're, in addition to alcohol, screening for tobacco and financial constraints, which is a very common problem, not just in our community, but across the country. Food insecurity, transportation, depression, housing. If we're not considering these things as we talk about alcohol use, then we're going to have trouble having an implementable plan that has an effect. And so we need to understand where our patients are coming from and how the treatment plan reflects their unique needs. And on top of this, there's the overlap with other comorbidities. We've been talking about this morning. This is very generalized compared to what we've been seeing before. But obesity, cardiovascular risk, aging, viral infections, they affect a healthy liver. But as we start talking about therapeutic options, what are we going to do about it? Because that's what we're here to do today. Lifestyle change, diet change, natural products or healthier foods. That's where we get to the social determinant risk. And how we're going to affect change, we need to be able to address those. Putting that in primary care we means that we need more help in how do we do this? How do we make this appropriate for our patients, the populations that are coming in? How are we treating obesity and diabetes and the multiple comorbidities that our patients are coming in with? All of those are in the scope of primary care, which makes this alcohol use disorder, this discussion, very relevant to what we're doing in primary care. And then a subset, mental health disorders and alcohol use disorder. We know that psychiatric disorders are worsened or are predispose a patient to using alcohol. They'll use more alcohol if you have an underlying psychiatric disorder. And then alcohol use also further worsens their psychiatric disorder and their genetic predisposition and environment that contribute to this as well. All this to say, for these listed disorders on the left and the groupings that there are: anxiety, mood, post-traumatic stress disorder, substance use, sleep disorders, and mental illness, which we encounter very frequently. We recognize that for many of these, alcohol use, 20 to 40% of the population is using with these mental health disorders as well. And so as we talk about the 4-quadrant model for care for co-occurring disorders, primary care is in the upper left, and we progress for alcohol use disorder to the right to addiction specialty or mental health if we progress lower. That in a restrained care environment or where we don't have great access is a difficult thing. So I would argue that this quadrant care is really appropriate, but primary care would be a large bubble of this. We would want to focus our efforts towards primary care. We've talked a lot about how do we get in front of these late stage presentations to our hospitals with decompensated liver disease. It needs to be in primary care. So we need to focus our resources around that and equipping our primary care doctors to be well adept at managing and using teams to do that. So this is how we talk about high-risk populations in our clinical setting in our organization. These are our community care clinics with our integrated care teams. On the left, we have a national model of health. 80% of the population in green is healthy. They only see the doctor once a year for an annual exam and maybe have some acute care. When you get to that 14% in yellow that are at risk, these are our patients with diabetes, hypertension, obesity, the list of things that affect the liver. And then we don't know who, but of that population, there's a rising risk transition where they go from at risk, multiple conditions to this advanced illness state. And that's the often quoted 5% of patients account for 50% of all healthcare costs. Our goal with our work is to target this populations at risk, that 14%, and actually probably more even the healthier populations as well, and what are the behaviors that are leading towards the at-risk chronic conditions. And this is not a passive process. We have to be very active and intentional as how we go about this. So community health workers that are embedded in our hospitals, that are embedded in our ERs, and in the communities where we're serving, they are actively bringing people, they're navigating people into our clinic in this care setting that's described on the right. So this integrated care team, we brought this up earlier, but I think this is really where we need to understand how to address complexity, social determinant of complexity, medical complexity together. There's access to care at the top. So that's the provider, patients in the middle. Access is really important. But then we have embedded pharmacy team. We have some specialty. It's not an integrated, it's not a huge network of specialty for our unfunded patients, but it certainly is some. But the things that we've seen that have been really impactful in changing the trajectory of health are chronic disease educators. So RN health coaches and community health workers that are talking about specific to the patient, what's culturally relevant food? How do you, I may say, I need you to eat a healthier diet. They can spend time on saying, this is an appropriate way to do this in your family. Let me teach you how to do it. These are places where you can go to get healthier foods and food deserts and otherwise. And I mean, that's just food, but we're talking about other components of how you address diabetes and lifestyle changes or any number of things, but this also can include alcohol use disorder. And then engaged or embedded behavioral health. So following the collaborative care model, we have embedded licensed clinical social workers that are addressing mental health. We recognize that 90% of depression, anxiety should be managed in primary care. And we know that there's a huge overlap with alcohol use disorder. We need to be addressing this where the patients are, where they can get care. And then using technology, we've piloted some things and hope to do a lot more with how we can use technology for education, and using the system effectively to develop care plans that work for our patients. So the proposed plan that I would put forward is saying that we're the front line. Primary care doctors are at the front line for our patients that need, and we need to understand them better than anyone else. We should allocate resources towards support and reimbursement for primary care to screen and pre-screen. We've talked about that already this morning. And using these care teams to have a plan that addresses alcohol use plus everything else, social determinant, comorbidities, all of those components. Using the subjective audit, but also incorporating an objective measure. The PEth test can be helpful to have a baseline in how we can assess
great things to say. So for those of you who don't know me, I am Laura Quacco. I'm Chief of the Treatment, Health Services and Recovery Branch here at NIAAA. I'm also a clinical psychologist and see folks that are in patient treatment program at the NIH Clinical Center. And I am really excited about this next session that I will be co-moderating with Stacey Sterling. And this one is on alcohol use screening and intervention in different settings. So our first speaker is Dr. Kathy Bradley. Kathy is a general internist whose research focuses on identifying and addressing alcohol and other substance use in primary care. And for over 25 years, she has conducted research that is really having a lasting impact on how medical providers approach prevention and treatment of alcohol and substance disorders. So without further ado, Kathy.
Let me say that slide was wrong. I don't have a PhD. It used to be truth in advertising. I'm a primary care provider. I practiced for almost 25 years before moving from the VA to Kaiser. So I will be talking to you from a pragmatic point of view, but have really focused my work on, there we go, primary care. I just wanted to start with disclosures that NIAAA does fund me a lot, of which I'm really appreciative, but also AHRQ has done a lot of our alcohol research. And let me just say, it's an honor to be here. I at first thought, why would a hepatology meeting want to have me at the hepatology meeting? But it's an honor. It actually turns out that the early liver transplant program at UCSF during my residency prompted my interest in alcohol, because I was a primary care internal medicine resident. And when I went to our faculty and said, so what do we do to prevent and to treat? They looked at me like I had said, how do I fly to the moon? I mean, it was something at that point in the late 80s, you know, it's like, oh, well, you do the cage and diagnose and refer. So it's great to be here. And that's where it came from. I want to ask if anybody in this room knows the very first brief intervention trial that was conducted in Sweden. So Jeremy May, that actually pertains to this meeting. This is great. So I'm going to tell you about it. It was by Christensen. It was published initially in 1983, and they took alternate year cohorts of men in Malmö, Sweden. They were actually doing an intervention on cardiovascular disease mostly and cancer prevention, but they decided to add on alcohol, and it was all negative, is my understanding, except for the alcohol. And what they did was they used GGT. They found out when it was high, they said, oh, you should come back every month and monitor that. And you drink, you should cut down your drinking if you do. And then every 3 months they saw a physician, and they decreased sick days and hospital days. I will tell you, it's a very messy, pragmatic trial that you do scratch your head going, which were these groups? But they also showed decreased mortality 10 years later. And so that I think I have that on a slide, that 2002 paper. So really pertinent that brief interventions started with this group. That led to brief interventions in primary care with Wallace, and then the WHO's 10-item audit, which is kind of when I came on the scene, and I was interested in studying the audit, and actually a head of a primary care clinic said, no, you can't study a 10-item screen for one condition in primary care. That's just not going to work. And that's what led us to start asking, how can we briefly screen? And that's what led to us looking at the audit C and validating it late in the 90s, mid 90s. And really the thing I wanted to say here, and in the introduction, I should just tell you, I'm going to run through my story in the introduction because it's got a lot of the take home points, and then I'm going to get more nerdy and pointy headed and give you some data, but I wanted to kind of hit on the high points. As a primary care provider, I got really sold on the third question of the audit C, because it became very clear when we looked at our audit data that that's where all the answers were. Those were the early points. And so I was really interested in using that. But we validated both the single item, the third item, and the whole audit C. And I'm glad we did, and I'll show you a lot on that because I've been convinced that it mattered. What happened next in my career, which I want to really highlight, is that the VA came to me and said, will you help us de-implement the cage and implement whatever we should do? And will you work with that? And I wanted to tell you about that because what we learned, we implemented the Audit C nationwide in the VA, which was fabulous. We also then measured huge quality problems. So it's not just go tell them to do it, but it's how you do it that matters. We can talk about that. The bottom line is you don't want to force people to ask the questions. You want to have the patient report it on paper or a tablet or on a portal or on their phone through the portal. So that's really the next take home. There are multiple brief screens, but how you do it matters a lot. And then the final, which is the reason I've become a convert to the 3 items instead of the single item question, and I'll dig into the details, is really we have to start thinking of this as a scale, just like we've been talking about. It's a spectrum. Liver disease is a spectrum. Alcohol use is a spectrum. And the Audit C, it turns out, this is a beautiful paper that Anna Rubinsky, who did her PhD with us, did with NIAAA data that shows average consumption across the Audit C scores. And the point I want to make here actually is that the Audit C, so we talk about it as a binary measure for brief intervention cut down here, but the point is right around 7 is where clearly addiction starts kicking in and consumption goes exponentially up. And so it's an incredibly valuable screen, and I'll show you more on that. This is the prevalence of alcohol use disorders. Note that it's not 100%, it's 80% at the top of that scale, but that's in the NIAAA data. And I should say this is Deborah Dawson's derived Audit C. It's not actually the Audit C in NIAAA. It's made from other questions. So it's a little different, but it's pretty close. So those are the big things. And the last thing I'm going to come back to is GDT and the value in liver disease in terms of feeding back potentially for this group to think about. So I'm going to go a little bit because I was asked to talk about population-based screening, and screening talks can be really boring. So I'm going to do this pretty briefly because I'm not sure how much you want to know, but there are multiple single item questions. The first publication was actually Dan Vinson's group published one, and then Williams, and then Rich Sace's group on the Smith article. And we had done the third question of the audit works well too. So the bottom line is they all ask about heavy episodic drinking, and they all ask about the frequency, recency, or volume of heavy episodic drinking. And that's really the key concept. This is the NIAAA question I put on the screen. One thing I want to point out, because people, I'm going to come back to why 3 questions instead of 1? Well, people say, well, do a pre-screen because you got to prepare them that you're going to ask them about heavy. And then you want to ask them about typical drinking, which is done in Kaiser, Northern California. And so you end up with 4 questions instead of 3. So I'm not a big believer that if you're doing a systems level screening that the single item actually saves you anything. And I think it has some losses. But I think where a single item question is really important is we did a study recently with onesie-twosie practices, primary care practices in Michigan. And let me just say that EHRs are completely unprepared to support any meaningful alcohol-related work. I'll just say it simply. But so for them, single item was, for 2 of the practices chose a single item so they could just ask it and have it be simpler. The Audit C, these are the 3 Audit C questions. Actually, let me make one other thing that's actually I did not know till I read this. The cut point in the Smith article is wrong, and it's corrected later by an erratum. But just know that the cut point on a single item question is ever in the past year, or if you do a 30-day question, it's ever. If you ever drink above the recommended limits, 4 for women, 5 for men, it's positive. So I just wanted to make that point. I think the Audit C, I'll come back to some details here. The thing I will say, the reason I put in parentheses here, or for on question 3, the frequency of drinking 6 or more drinks, how often do you drink 6 or more drinks on occasion, is that we validated it in women in the VA with 4. And it doesn't, I'll show you later, it doesn't make a difference. It doesn't make a big difference. And we'll come back to the confidence intervals around sensitivity in these studies. And so you can do either, and we'll talk about pragmatically what drives that. So what does it mean to validate a screen? I think I have to say once somebody has alcohol-related liver disease, screening is we're done with screening, right? We're now, we're not talking about screening. You want to know whether they drink. But the reason I wanted to make that point, all validation tests of the audit C and of the single item screens, to my knowledge, unless somebody stands up, and says otherwise, and I keep asking everybody, have been validated confidentially. So that means the screen was confidential and the interview was confidential. And that means that we actually don't have a validation study that has them in the EHR. Now I'm going to show you data. I think they're valid in the EHR, but it depends how you implement them more than the screen. And that's going to be really the take home. So this morning, they've been validated for AUD, they've been validated for risky use, and they've been validated for both unhealthy alcohol use. And the key concept is that, the key concept is they're validated in this very confidential setting. I think that's really the key thing. And so it's really how they're implemented. These are the sensitivity and specificity for 2 studies. This is our non-VA study of the Audit C and Rich's group's validation of the NIAAA single item screen. And the thing that the next slide will show you, or I'll show you, is these sensitivity, people get really like, oh, but that screen's more sensitive because look at the Audit C says 86 to 89 and the other study says 82. Well, the confidence around sensitivity in these studies, because the number of cases is quite small, is usually 20 points. Okay, so the haggling over which screen is more sensitive, be done. Just pick a screen and use it and then care how you implement it is really the take home here. The next slide, I put together all the studies that I knew of in primary care on single item screens or the Audit C, and some of them did both. And I put in for 2 of them, I put in the sensitivity and specificity. They don't all, we didn't publish. We published the confidence intervals around the areas under the ROC curves and the likelihood ratios, but not sensitivity, specificity. But I can tell you that they're wide. So if you look here, whoops, sorry, that's not what I wanted to do. If you look at the Smith study down halfway and then the very bottom row and the very first column for the single item screen, you'll see that the confidence intervals there, when you lump men and women, which you really shouldn't do, generally, because they perform differently often, you get about 15 points. Actually, in Jen McNeely's study, you get, 15 points there. So that's the big takeaway is don't haggle about the variable sensitivity. Pick a screen, use it. I wanted to show you this screen, which is from Jennifer McNeely's single item screen, because I wanted you to look at the very top line of the sensitivity in women of 75. And I wanted you to look at the confidence intervals, which go from 60 to 85. So usually these studies, if they get into small groups based on race and ethnicity or sex, the confidence intervals are 25 points. And so specificity way more, and it depends on the prevalence often. So why 3 questions if one works? I already kind of alluded to this. I've become really convinced, and I'll hope to convince you, that the Audit C gives you a scale that's, I think of it, and this is important. People say to me, the Audit C is too sensitive. Like people who, like women who score 2, they're drinking way low. But it's the scale that we're going for, first of all. And it's the first 2 questions are actually insensitive. But meaning that the first 2 questions, if you take them on their face value, you underestimate consumption, but that's why we use the score. The score is validated. The actual consumption on questions 1 to 2 is about half of the actual consumption. The 3rd question doesn't underestimate. It actually, if anything, may overestimate. But the bottom line is use the score. It's not about the face validity, and don't get into haggling with the patients about the quantity frequency either. So this is how do you implement it? And this is what I wish I'd actually had the 5 slides on, because I want to say a little bit about what we know about implementing. We know it takes systems. We know it can't be, Stacy's group's work showed us that it shouldn't be the primary care provider. It should be somebody else. But in Michigan, where there might be no staff in a primary care provider, it might have to be the primary care provider. And then you have to have systems in the EHR. Our EHRs are unprepared right now to handle this work, and that should be a major focus of infrastructure development. You have to normalize it and address stigma. It should be annually, I believe, at least, and sometimes it's just practically easier to do it with everything. But the next bullet point is most important. It has to be integrated with other things in primary care. And if we, as alcohol researchers, keep going it alone with our disease, we're going to lose the battle. So what we did and it's not on this slide quite yet, but what we did in Kaiser, Washington, is a trial where we implemented with, and this was driven by the health system. It was actually driven by my partners. We integrated it with depression screening, alcohol, cannabis, because it's legal in our state, big issue, and then other substance use. It could be with tobacco and other things, but it must be integrated with the other things that primary care practice cares about. And then it must be self-report from the patient on paper, on a tablet, by phone, or on their smartphone, or through the EHR portal. And I say that the reference is here, that the JGIM 2011 reference shows that in the VA, where we just had people asking it however they wanted, and my nurse and my clinic would ask patients, "You don't drink, do you, honey?" And then they would answer the audit C. And the other way it worked, actually, Emily Williams, who's part of our group and wrote a bunch of study qualitative on what was explaining missing half the people. We actually saw with an observer in the room where they'd say, "Oh, if I put that in the record, they think you're an alcoholic, so I'm not going to record your answers." I mean, we saw all manner of crazy behavior. It was all driven by an effort to make the patient feel comfortable. I want to really stress that. It was driven by an effort to overcome stigma. And so stigma and normalizing it. What we do in Kaiser is all patients every year answer these questions as part of whole health. Okay, so we're normalizing it and we're doing it. And I didn't develop that script. We worked with teams and they developed those scripts, and each medical assistant had their own script that was comfortable, but it included normalizing it. And then finally, systems. We need, prompts like, when does the patient do? And it should vary. We were just talking about, if somebody has liver disease, you might want to assess their consumption at a different frequency than if they don't. And likewise, if they have any manner of other reasons, medical complications already of their drinking. The things, I wrote myself some notes earlier, things that are not on my slides that I wanted to stress. Primary care has systems to improve quality, and that we do plan, do, check, adjust, or plan, do, study, adjust, cycles, iterative cycles to improve quality. We do it for diabetes, we do it for hypertension. Those systems work with alcohol. That's what we showed in the SPARK trial. The SPARK trial, by the way, we implemented with this screen, and I'll show you, and then we did a DSM-5 checklist for alcohol use disorders, and we increased screening to like 90%, brief intervention, alcohol use disorder diagnosis, and initiation of treatment in a single system that we implemented, but we did it with primary care quality improvement practices. And we had in that work, we had a practice facilitator who I would argue is probably going to be essential if we're going to spread this into primary care practices across the country. They use practice facilitators, 2 minutes, are done for everything. Okay, I'm going to just say a word about alcoholic liver disease, and I'm not going to give you this is thanks to NIAAA, Kevin Hallgren and I have a grant to look at our data with Audit C, and this is the AST and the ALT across Audit C scores. So that just, again, this mimics what Anna Rubinsky showed with NISARC data, that it kind of goes flat and then it goes up slow and then it goes up much faster. This is the hospitalization rate across the Audit C. And most of this is alcohol specific conditions. When you get up to the 9 to 12s, we're moving to zones like the WHO has for the audit. So we're using zones more and more. I want to just say a couple words on how do you then move from a consumption measure where you can be, there's a high probability of alcohol use disorder symptoms, to making a diagnosis. And the norm when we started our work in Kaiser, Washington was we're going to do another screen. And my feeling as a primary care provider, and then the notion is the primary care provider will do a detailed interview to diagnose. And like when the hell freezes over, right? I mean, that was not going to happen. And so we moved straight to a DSM-5 checklist for alcohol use disorders. We have one for substance use disorders. It's now been, thanks to NIAAA, psychometrically validated. It looks like this. And we did this not because we knew this was valid. We actually didn't know when we started how many people would even tell us about their DSM-5 symptoms in a yes/no questionnaire. Well, it turns out a lot did, but what we used it for is an engagement tool. Because I, as a primary care provider, could say, oh, you said you wanted to cut back and you couldn't. Can you tell me about that? I mean, these are all conversation starters. Can you elicit from the patient what's bothering them, and then you start the conversation. And so that's how we implemented it. We now know it's psychometrically valid. I'm not going to show you that. It's published by Kevin Hallgren, but I do want to show you, because this was the first question we had is, will anybody tell us symptoms? This is the prevalence of mild AUD or more across 7 to 12. We only do the checklist if people are at 7 and above. And honestly, that was driven by burden on the health system. It's the top 2% of drinking in our system. And I'd probably go a little lower, but we couldn't manage that. But you can see that basically what happens is what's getting more prevalent is the severe alcohol use disorder as you go across there. And that was published by a medical student working with us in 2020 in JGIM. I think the rest, yeah, I don't think I have to go over. I want to show you one more thing because I did it last night on the plane just for the study and it's fun. So this is the question. So those AST values that went up across the audit C, those were between 2 audit C scores. They were actually, I was showing you the first audit C and the AST. And this answers the question of the people who went to 0 on the second audit C, what was the decrease in the prevalence of elevated AST? And so you can see that if you were in the 9 to 12 group, those people, basically there was a 24% reduction in the elevated, having an elevated AST if they went to 0. So I just thought that was fun. We've published other studies showing that a change in audit C predicts a change in mental health systems, a decrease in all-cause hospitalizations. So it's a good measure. I mentioned the GGT in Malmo, Sweden. That's been done with pancreatitis in a similar way. And Mark Willenbrung, who used to be in the NIAAA, did it in primary care patients. And I think that's where the money is. I'm going to skip that and I'm going to say thank you. And really appreciate and happy to take questions later.
Great. Up next, we have Dr. Ann Fernandez, who is an associate professor in the psychiatry department at the University of Michigan. She's a clinical psychologist with expertise in behavioral treatments for addiction and alcohol-related liver disease.
Hello, everyone. It's really exciting to be here and hear everyone talking about this topic, having worked in this space, and then having everyone in a room talking about this is it's just really exciting. So thank you so much for having me and allowing me to speak. So I'm going to talk about brief interventions, which have come up a few times throughout our talks already this morning. I'm going to define them. I wasn't sure how much background everyone had in this, so I want to make sure we anchor ourselves in what a brief intervention is, and an overview of what they entail, and then talk specifically about how they fit with individuals with the ALD and what potentially adaptations or special settings we may be able to use to increase access to brief interventions for people with ALD. So what is a brief intervention? And I'm going to answer the question, although a brief intervention can be many things, but generally speaking, this is a structured client-centered therapeutic encounter. Initially, this would be something that would be clinician-driven and in-person. That's not the case currently, but traditionally that's how these were developed in a non-specialty alcohol setting. So bridging that gap between prevention and treatment and trying to get some services to people who may have lesser severity alcohol problems, but need some intervention, and then potentially moving them into a higher level of care as needed. It can be a harm reduction practice, so it can be focused on an abstinence goal. It could also be focused on other goals. So somewhat agnostic in that sense, but the idea is basically to prevent harm and consequences or escalation to alcohol use disorder. It can range from brief, as in 5 to 10 minutes, or an hour-long session 4 times. Research doesn't really clearly indicate that longer is better, so that's good news. And it can be delivered by a clinician or digital format. There's several talks on telehealth and e-health tools, so I'm really going to focus more on the clinic-based applications here. And this fits within a model called SBIRT that many of you may be well aware of, where screening is the first step. So you can't do a brief intervention unless you know what people are bringing to the table. And that should generally be a universally given, like you give it to everybody, not just people who look like they might be drinking, whatever that means to you, with a validated tool like the Audit C. And then based on that score and cutoff, you would have a brief intervention. And that would be for people with risky drinking cutoffs. We'll talk about what that means. And for those who are drinking at harmful, higher levels, a referral to treatment or some higher level of care. Some standard cutoffs for what risky drinking is that would trigger a brief intervention is that upper quadrant of the triangle there with the red dot around it, where both consumption and consequences are higher, but we're not in that tiny top 2% or 5% of people at that tip of the pyramid. This can be applied even to people in that more risky phase who may be transitioning into worse use, or who may just have some level of risk even at their low level of consumption. As we know, that even a drink a day or 2 drinks a day can really cause a lot of even health conditions we're coming to know more and more. So a cutoff that's standard could be an Audit C of equal to or greater than 4, or an Audit C of equal to or greater than 3, or 2 in the case that Dr. Bradley was showing. But we use some cutoffs to determine who would get these. And then my goal here is definitely not to teach anyone how to do a brief intervention in 15 minutes, but just to go over what components. They typically will use a motivational interviewing based approach or style of communication, which as was pointed out earlier, is a skill that you can develop and get training in. Anyone, MAs, nurses, doctors, anyone can get trained in this in our integrated clinic at Michigan. We have every staff member is actually trained in motivational interviewing. And also a really effective mechanism that's been shown in research is personalized feedback. So when someone feels like something is tailored to them, they tend to listen more. So if this can be tailored, whether that's just to the person's Audit C score, you know, for you, your score is this, and that means this based on what we know, even that can help people kind of grab onto the information. And there's a lot of different ways to tailor that I won't go into. And then another general structure is frames. There's a lot of different brief intervention kind of models, but this one is basically the idea that you give feedback. You emphasize responsibility, that it's the person's, they're autonomous, they're responsible making their own decisions, and you give advice. And I want to pause to mention that there are some really interesting qualitative studies of how people talk to their patients about smoking and how they talk to them about alcohol. And smoking, they'll say things like, you should stop smoking. And that would really be good for your health. And then for alcohol, they'll say, wow, you're really drinking a lot. Maybe you should think about cutting back. And sort of like this jokey, casual, uncomfortable way they approach the conversation. So my advice, to be consistent with what I'm saying, is to be very specific and clear with advice, health recommendations around alcohol within brief interventions, while holding, in the other hand, a harm reduction model. You can be very specific about your medical recommendation and still meet someone where they're at, support them in their reduction or just reduction of consequences if they're not even willing to change, while also giving clear medical advice. So I think those two things really need to kind of work together. And to give people a menu for change. People often don't like to hear, you have to go to AA, it's the only thing, because it's not true. There's a lot of things, so knowing that, knowing digital tools, knowing all the options is really helpful. Literally, you could even have a menu, 6 things, here are things you could choose from. And then I have a typo, Self-efficacy is the idea that really empowering the person to do this for themselves. So frequent settings for brief interventions or SBIRT are things we've talked about, primary care and other community settings. These can be done outside of traditional clinic settings and in community clinics or just settings where you'll see a high number of people in an alcohol using population. So this slide is just to say there's so much online for resources, and so you can do some Googling and find all kinds of things. So now I'm going to shift just a little bit to talk about how to incorporate individuals with ALD into brief interventions, with the caveat that the main message is do brief interventions with people with ALD. That's really, I could stop the talk there. But I'm going to get a little more nuanced, but that's really the most important thing is if we're doing this for people who have alcohol use disorder or risky drinking, we're doing this with people who have ALD. So really just increasing uptake and implementation of brief interventions is going to hit this goal. But with that said, there are some things that we can think about. So I'm actually going to show a lot of the same slides I just showed, but with some red text to indicate some potential adaptations. So one emphasis, so I think like we do with pregnant women, there isn't research that shows any amount of alcohol that's safe if you have liver disease. So I think we also need to incorporate that messaging when we're giving advice to people or thinking about who needs a brief intervention. Is if you have liver disease and you're drinking, that's harmful drinking. So I think we need to kind of shift how we think about that. Although many of us are already thinking in that way, but maybe to just make it a bit clearer that these are people with medical conditions for which alcohol use is even less recommended. And so that may mean if someone has a known liver disease, even if it's not from alcohol, that the message or even the mechanism may be that brief intervention should be given to anyone who's drinking who has liver disease, which would be a slight shift in how the model's deployed currently. And I don't know how that's specified in the billing codes. So, you know, if someone has ALD and they're not meeting that audit C threshold, can you bill for that? I think that's a question I don't have the answer to, but something to think about. And then referral to treatment, also having a lower threshold. Even this is something that comes up in our clinical out in Michigan is even for people who are recently abstinent, if they have an alcohol use disorder, they're at risk of relapse. It's a chronic health condition, chronic relapsing condition. So to also refer people who may be at risk for relapse. And then potentially shifting some of these cutoffs for people with ALD such that we could incorporate people even at those lower risk levels of drinking for these brief interventions. And then in terms of some of the components that I think we could work to do some adaptation with is in the personalized feedback space. So like the GGT or doing liver function tests or other things that you can really start to incorporate feedback to people. Or I had the thought as you were presenting, Dr. Bradley, is could you just attach the brief intervention to biomarkers? Say you have to come back for biomarkers. And then as one of our colleagues, Dr. Winder likes to say, you do ambush psychiatry. You just trick them into coming and then surprise them. So if you can get people coming back, then you can attach the brief intervention to the point of care that maybe you've created, not an artificial way, but in a way to create a repeat visit, because people will come to medical visits. They'll come for tests, but if you say, come back and chat, they're like, yeah, no thanks. So as much as a psychologist, I want them to want to talk to me, I'm aware that that might not be the first thing they want to do. So I think there are some clever ways to try to either integrate people in clinic or to get them to come in. And so just a little bit about settings for brief interventions. So again, primary care clinics, this isn't a surprise. So I think doing standard brief interventions plus the more aggressive monitoring of liver functioning and giving feedback about that and risks for ALD. And I think there's a lot of creative work that people could do in this space and potentially do research on. And then referral to specialty care and also to hepatology care as needed. And then if we train, so in hepatology or GI practices, I think this is the other big place. I don't know this for sure, but I don't know that any hepatology practices or GI practices require people to know motivational interviewing or brief interventions, which is kind of wild if you think about the diseases that they're treating. And the fact that ALD is the biggest portion of liver disease at this point, and the only treatment that works is basically getting care, or getting some kind of brief intervention, some kind of referral to care with medication. We don't have people said it, we don't have a pill for ALD. We have alcohol use reduction and abstinence, end of story. So we really need to get providers trained in how to have these conversations with people to make that happen, and to have it not be something where it is just not someone's job, like it's just part of the job. And with that said, you should also integrate people who have this expertise, because you can't put it all on the MD, who's also very busy. And then building connections with addiction clinics and community partners, creating the long hallways, as Dr. Mellinger has used that term, what I like. It doesn't always have to be a warm handoff. You can create a connection, and leverage the consistency of the medical visit to have brief interventions at every visit. And then flipping the model for ALD brief intervention in addiction care. So actually put the liver doctor in that clinic once a month, and maybe have, some conversations with people, or start monitoring liver function, or doing fibro scans, and kind of flip that model totally in reverse would be another novel way to do this. And I don't know how much time I have. I'm almost done. Okay, perfect. Thank you. So with all of that said, one reason, there's many reasons it's important to provide brief interventions to those with ALD, but I want to highlight just the gaps in care that we have, which this was a paper I worked on with Dr. Mellinger, where we looked at people within 1 year of their ALD diagnosis, where we were hopeful that getting into AUD care would be more likely after such a severe medical diagnosis, and often event that led them to get that diagnosis, and found that only 10% of patients with ALD had any AUD or mental health care. We made a broad definition. It just didn't have to just be addiction. It could be any mental health. Only 1 in 10 people got that, and less than 1% had gotten an FDA-approved relapse prevention medication. And so the point being is that everyone orange here is someone who, if they had a brief intervention, that would be the only care that they got. So we think of this as a little touch point, but actually it might be 100% of what they get. So this is a huge opportunity to get care to people, if we think about it in those terms, even if the effect is somewhat small. When we look on a public health level, this is really important. And then in closing, there isn't research on SBIRT in ALD that's randomized control trial. There's very little, and I don't think this is a special population in the sense that we need new efficacy studies, but we do need some, larger scale trials to look at this, and potentially make some tailored adjustments and recommendations and put them together. And I think I heard some people saying, tell me what to do, tell me what to say, to package that. And maybe that is what can come out of this meeting. So yeah, thank you.
So next we will hear from Dr. Derek Satry. He's a clinical psychologist and professor in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco, and adjunct investigator at Kaiser Permanente, Northern California, Division of Research. His research focuses on addiction and mental health services, including behavior intervention, development, and testing, studies of screening and treatment in primary and specialty care settings, and the use of digital health technology to address alcohol and drug use in a range of patient populations, especially those with co-occurring mental and physical.
Great, thank you very much. And thank you very much for including me in this great meeting. And I think this next talk is a nice sort of next step, building on the talks that we just heard about brief interventions as an example of a trial that's ongoing and work that we're doing in adapting a brief intervention model for a telehealth delivery at UCSF. So I'd like to thank our funders and Mandana Khalili, the contact PI and my partner in this work at UCSF. And I'll just jump right in. So just by way of background, we've already heard a lot about the importance of brief intervention models in liver care. So I'll touch on that very briefly. Some work that we've been doing in BI adaptation for chronic liver disease in hepatology specifically. And then I'll describe a brief intervention. It's somewhat on the longer scope of brief intervention length that is being tested in combination with a stepped care model with referral to addiction medicine, which is in process. So it's a stepped care intervention study model trial, followed by some analysis of baseline data looking at factors associated with motivation for patients to cut back on drinking. And then some additional lessons learned and clinical sort of context. I'm a clinical psychologist and I've been doing the interventions, the MI interventions myself in one of the sites. And it's been really fascinating to see the presented clinical issues, motivational factors that are similar to some of the prior work that I've done in patients with depression and HIV in the past, and kind of moving into the liver world. So as we've heard already, there really is a need for brief interventions based in hepatology, lots of reasons, and our colleagues at Michigan have been leading the way in publishing and doing some initial work on this, looking at barriers to alcohol treatment for patients with liver disease problems. Patients may have misunderstandings actually about the impact of alcohol on their liver. Surprisingly, we would think this is a very clear connection, but sometimes patients don't understand it, may not understand treatment and what that includes, may be unwilling or unable to access specialty alcohol programs, and may benefit from brief interventions, as we've seen in other clinical populations. So prior work has often focused on alcohol use disorder. And so, for example, in the context of liver transplant and higher severity, but we really need to be addressing the whole range of alcohol problem severity. Telehealth has greatly expanded accessibility and options, but has its own implementation challenges. And as just noted previously in Ann's talk, patients may need linkage from hepatology to more extensive treatment, including following the SBIRT model. Okay, so we have adapted an alcohol brief intervention model for patients with chronic liver disease to be tested in the context of this study. It's based on the core motivational interviewing strategies that we've heard a little bit about already, which include reflections, open-ended questions, providing information, and the goal being to enhance motivation, to elicit change talk for patients to express an interest in cutting back on alcohol use, and then to develop a plan to do that. So our approach also integrates the context of care that patients are dealing with, including high comorbidity, multiple medical and psychiatric problems, and I've seen from my own discussions with patients barriers such as friends and family who drink, as well as social isolation issues, housing, and then navigating the health systems where patients are receiving care. So this approach builds on experience with prior MI trials that I've led in the past, based in psychiatry, as well as HIV alcohol clinical trials, with Stacy Sterling as a partner in work that's been done at UCSF as well as Kaiser Permanente. So then our trial that is in progress follows this approach. It's a stepped care model. We're recruiting patients with chronic liver disease from 3 hepatology sites serving vulnerable populations, 2 VA sites, Palo Alto and San Francisco, as well as the Zuckerberg San Francisco General Hospital. So we're including adults with chronic liver disease and risky alcohol use in the prior 30 days. English and Spanish speakers. We're excluding those who have severe medical and psychiatric disorders or are not able to consent or participate. So the intervention model includes 3 sessions of motivational interviewing, which is followed by being stepped up at 3 months if patients still report drinking. And if patients are willing and clearly need more extensive help and are interested in medications, we have been stepping them up early if they are in need of that and open to that. We see that as, so it's kind of a packaged stepped care model that we're testing. And patients are assessed at baseline, 3, 6, and 12 months, supplemented by chart review, looking at clinical and laboratory measures, including diagnoses, comorbidities, et cetera. Alcohol use is measured. We've got a number of measures looking at lifetime alcohol problem history, and then the timeline follow back for our primary outcome measures for alcohol use. So this trial is ongoing, and we are nearly at the end of our recruitment. And we've started to take a look at the baseline characteristics of the sample, and with an initial focus on factors associated with motivation to reduce drinking at baseline. So the reason that we're looking at this is because there really is substantial variability in patient recognition as to the importance of alcohol use reduction and confidence and ability to cut back. And among those with unhealthy alcohol use, it hasn't been well studied in patients with chronic liver disease, although there has been a little bit of work in this area. These dimensions of motivation have been associated with subsequent drinking behaviors and treatment response. And so we examined key clinical and psychosocial factors associated with importance and confidence in alcohol use reduction. So our sample is including 121 patients. We're using baseline assessments, including sociodemographic questionnaires, the GAD-7, PHQ-9, and the audit, as well as measures of liver disease severity. And we're using outcomes based on importance and confidence to reduce alcohol use using these readiness ruler measures that have been used in a number of other studies, and then looking at factors associated with these outcomes using linear regression. So our sample is 84% male, racially diverse, with a mean age of 61. The mean audit score was 16, mean importance on a scale of 1 to 10 was 9, and confidence was 8. So fairly high self-reported importance and confidence, and these two measures were somewhat correlated. So in our multivariable analysis, we found that being in the VA site, participants had somewhat lower importance score compared to being in the general hospital site. We also found that scoring positive for depressive disorder on the PHQ-8 and higher audit scores were associated with higher importance score. What we didn't find as significant was anything associated with liver disease etiology, severity. We also looked at pandemic-related stress and prior experience with the alcohol treatment system. So in summary, we found that motivation scores were high. Again, depression was significant, as well as study site, but none of the factors was associated with confidence. So we had some signal for importance, but not for confidence. And these results are going to be presented at a couple of upcoming meetings, Digestive Disease Week, as well as RSA. So implications include, I think, that mental health and alcohol problem severity, as well as population or health system effects, could help to inform or enhance brief intervention models. Distress and alcohol problems seem to be motivating, and these could be further integrated into intervention approaches. The effects of health system, we're not completely clear if these are population effects or factors significant to what patients thought they could access within the health system where they were being recruited and where they received care. So this needs to be explored. The lack of impact of liver disease severity measures on importance suggests perhaps limited patient understanding of effects, or that this needs further work from a patient-centered point of view to educate patients, and perhaps this needs to be part of the broader scope of interventions that includes education as well as motivational interventions. So additional clinical considerations, lessons learned. We really found that patients were reporting multiple challenges. I've mentioned mental health several times already, and patients often reported use of alcohol specifically to manage these mood symptoms in the MI sessions. A lot of other substance use, stimulants, smoking, cannabis. Patients reported trauma and grief. Several patients who I worked with reported recent loss of a child to violence and a lot of significant social and family problems, as well as family members who were heavy drinking. And this was an issue, especially with some Latina patients I worked with who were really heavy drinking family events that they felt left out of if they didn't drink. And these patients had liver disease. As well as other social problems, housing, limited support, financial stress, and the need to keep working. So sometimes people were motivated by needing to get better so they could go back to work. And these are older people who are pretty ill. So additional factors relevant to telehealth and BI, we actually found, we recruited patients in multiple ways, by phone and also in person. We actually found that on-site recruitment was most effective, even though this was a telehealth intervention model. The hepatology, behavioral interventionists, and addiction medicine providers worked very well in collaboration. And this is something I don't really have to have a lot of time to get into, but it was alluded to in a couple of the other talks. So we had our, we recruited from hepatology. We worked with behavioral interventionists who were connected to hepatology, psychologists at all 3 sites. And then addiction medicine providers were site-based. So we were able to kind of all work together to implement the stepped care model. And I think this is a good approach going forward. It really takes a team, hepatology, behavioral interventions, and addiction medicine to help this population. Patients, in terms of telehealth, patients often preferred the phone to video, which is easy in some ways, but I think you also lose a little bit. Sometimes people are distracted. They're on their way somewhere. You're trying to get them in a quiet place. You don't get that face-to-face video. So, but not everybody has access to that, to like a nice stable Zoom setup. We found that MI delivery by a Spanish language interpreter was actually pretty well received, and that seemed to go well. We'll see what it looks like in the outcomes in terms of our Spanish language participants. And as I mentioned, we did step up patients to alcohol use treatment medications that they were interested in. And some patients were quite interested. Some of them seemed not open to it. So I think this is where a lot of education and additional work can be done to further understand patient understanding and engagement with medications. So we are almost done with our recruiting. Results should be available next year. We're going to be looking at intervention effects, of course, as well as the predictive value of our motivation measures and thinking about next steps. Summary and recommendations. We really need to develop and test interventions across a range of alcohol problem severity, integrate other substance use, psychiatric comorbidity into intervention design, integrate interventions into hepatology, extend use of telehealth, test patient-centered interventions to enhance motivation, including education, and also address broader health system integration. So linking patients to addiction medicine when needed, psychiatric services and social services. And again, just want to acknowledge my collaborator, Dr. Khalili, who's going to be speaking tomorrow. And this sort of illustrates our outstanding team of hepatology investigators, addiction medicine staff, biostatisticians, and patients at our 3 different sites. And thank you again to our funders as well.
Great. So next we have Dr. Allison Lin, and she is an associate professor and addiction psychiatrist who directs the Addiction Psychiatry Fellowship Program at University of Michigan. She's also a research scientist at the VA Ann Arbor Healthcare System. Her work focuses on using healthcare data sets to understand gaps and barriers to addiction care, and then developing and testing new treatment models, including incorporating telehealth to improve treatment and outcomes for people with substance use disorders.
While we're getting my slides up. It's great to be here. No worries, take your time. It's great to be here. This is a really exciting setting. Similarly, as a non-hepatologist, I was wondering why I was invited to something like this, but after just hearing this morning, I think that it's just so exciting for all of us to be having these conversations together. I will be building up on the prior discussions, and I really hear some very similar strands that hopefully can bring further conversations among us. The key things, though, that I will be further emphasizing on are really the contributors to why the treatment gaps currently exist and what really are new strategies we need to be thinking about, including but not limited to telehealth, in order to address the barriers that we know currently exist. So this has already been emphasized before, but I think it still bears emphasizing in terms of the magnitude of the problems that we currently face. The best estimates show that only about 10% of people with alcohol use disorder nationally in the US, not just among ALD patients, currently receive effective care. This, by the way, is actually probably much lower than for effective treatments for opioid use disorder, where we have similar barriers to care as alcohol use disorder. And importantly, in alcohol use disorder, we have multiple effective strategies, both multiple effective psychotherapies and multiple effective medications, but we see far lower treatment rates. And as has been emphasized before, this is an even more larger problem with medications. So our currently estimates show that only less than about 2.1% of people with alcohol use disorder receive a medication treatment, one of the 3 FDA-approved medications. And what this means to me is that we need to be using all the tools in our toolbox, and we are definitely not doing that currently. And this also suggests that we probably need different strategies to try to increase uptake of these different types of treatments. And I very much can think about the different contributors to barriers to medications for alcohol use disorder, but we need multiple strategies to increase uptake of our current effective treatments. So I'm a pretty simple person. To me, it's really helpful to think about, well, so why? Why are treatment rates so low for alcohol use disorder? And what are the main contributors? And then what can we do about them? And for me, the mental model that I have about this question are really a combination of 3 factors: stigma, the complex underlying symptoms of addiction or substance use disorders, and lastly, our systems of care and historically how they've come to be and how they've evolved. I'll talk about stigma in the next slide, but I really want to emphasize an underlooked factor, which is really the definition of addiction itself. So substance use disorders are the one medical illness that are defined by the fact that someone's going to have a hard time making a change despite having negative consequences. What that means to me is that by definition, people are going to be ambivalent about treatment. What that also means to me is that we should be making alcohol and other substance use disorder treatment more appealing, more accessible than any other form of medical care we deliver today. For example, like how we offer cancer care. And unfortunately, most of us who work in the addiction field know that that's not what it looks like. And this plays out in many different ways. I was thinking about kind of all the talks that we were having this morning. You know, thinking about what it takes for a patient to get to my door, it oftentimes means that they had to be willing to mark yes on audit C questions. Their primary care provider had to be open and felt like they had the self-efficacy or ability to talk to their patients and engage them and able to enhance motivation. Then to be able to put a referral in, and a referral really means here's a list of phone numbers for you to call, for patients to call that list of phone numbers, potentially with wait lists, and then for them to show up at an initial intake appointment, sitting in that waiting room, experiencing the stigma that's associated with it. And then oftentimes what we know happens is that once the patient enters that first encounter and they tell the provider, you know, I'm not sure what I want to do with my drinking. We know that 95% of people with alcohol use disorder are not interested in stopping drinking. But oftentimes when a patient comes into an addiction treatment program and says, you know, I don't think I want to stop drinking. I don't know what I want to do. My doctor told me I should come here. Oftentimes the response they get is, well, come back when you're interested or willing to stop. Right. So no wonder we have kind of such large treatment gaps within kind of the care that we deliver today. And so I wanted to go back to stigma as a factor because that really magnifies everything that we're talking about here. We know alcohol use disorder is highly stigmatized, and it's really at multiple levels. It's at the healthcare system level, it's at the individual level. As an addiction psychiatrist, I work a lot with stigmatized conditions and populations, but substance use disorders are still the one condition where I see more than anything else, patients waiting 5 or 10 years to come seek care, walk into my door for the very first time. It's that shame, the guilt, the self-loathing, and not understanding that they had an illness that deserved to be treated. If we could only decrease that time span to treatment, imagine what we could do in terms of reducing poor outcomes. We know from prior studies that feelings of stigma are associated with reduced treatment use. And also, we know that people say they prefer to get their treatment outside of clinics like the places that I currently work. For example, in primary care or other liver clinics potentially or other healthcare settings. And so the question is, well, what do we need to do in order to make care more patient-centered? What does that look like? What does that really mean? And so I haven't talked at all about telehealth yet, and this is important. This is not just about telehealth. It's really about how do we rethink care delivery to engage the 90% of patients who are currently not care seeking at all. And I think, you know, this is an age-old topic. This has been going on for hundreds of years, if not longer, as long as alcohol has been around. But I do think we've made substantial gains even in the last decade in terms of thinking about this problem and addressing it. One key example is obviously NIAAA's recent work published in 2022 about redefining the research definition of recovery, saying that recovery is a process through which an individual pursues both remission from alcohol use disorder and cessation from heavy drinking. Recovery is often marked by the fulfillment of basic needs, enhancements in social support and spirituality, and improvements in physical and mental health, quality of life, and other dimensions of well-being. I just want to emphasize, you know, this new definition. I think most of us see it and are like, oh, this is great. But it really is a radical shift in the addiction field, where the primary focus historically has been focused on no drinking or no substance use. That's the primary question we ask all of our patients, right? And what this definition says is that it's about, you know, not meeting criteria for alcohol use disorder, which means not having 2 or more symptoms on the DSM-5 11 symptom checklist. What that also means is that you can have 1 symptom, for example, craving. And also the DSM-5 11 symptoms are not defined by amount of drinking. They're really defined about consequences. And of course, the other piece is about cessation of heavy drinking, because as we know, that's a huge hallmark from consequences. And so this is a really important start. I think as a field, we need to know, we need to be thinking about what this means. Where do we take this definition? How do we talk to patients about this, right? As a clinician who's focused on saying, obviously no level of drinking is safe. Thus, I need to be telling my patients that they should not be drinking. But then what's the next step after that? When we know that for patients who are not really interested or very ambivalent about stopping drinking, what are the things we should be thinking about or talking about after that? And of course, the WHO risk levels are also extremely helpful, right? The fact that before we defined alcohol use disorder, now we're defining risky levels of drinking, which is based on quantities. And so studies showing that across these 4 risk levels, which differ obviously by men and women, reductions of 1 to 2 risk levels are associated with improved functional outcomes, improved liver enzyme values, and other improvements. And what that means is that when you're working with someone with severe alcohol use disorder, you don't have to go from that to saying no drinking to achieve success for the patient and also achieve numbers that we sometimes care about too. But then again, how do we operationalize this? When I gave this talk last week, a similar talk, someone said, well, does that mean I should be telling my patients to drink? And no, that's not what it means. But there is this gray area in terms of what kind of conversations should we be having with our patients? How do we take a field that's been focused on no drinking to a field that prioritizes not only quantity of drinking, but also patient engagement? How do we reconcile both of those goals at the same time? All right, now I'm going to talk about telehealth. I do a lot of telehealth research. And because there's been a group of us who've been thinking about these questions from a lens of telehealth. I was very much an early adopter of telehealth working in the VA because I was lucky enough to work with the faculty and our attending who have been using telehealth well before the pandemic. We were doing telebuprenorphine care from our Ann Arbor healthcare system to patients at that point in community-based rural clinics, never to patients at home because that was too scary. And of course, things changed quickly recently. Our team conducted one of the first systematic reviews looking at effectiveness of telehealth-based clinical treatment interventions for substance use disorders. In psychiatry, we've long known for decades that telehealth delivered interventions are non-inferior, right? Non-inferiority studies have a much higher power kind of requirement. And there's just tons of studies for depression, PTSD, et cetera, that show that telehealth delivery of care is non-inferior to in-person care. But when we conducted a systematic review, we realized that there was almost very little literature in substance use disorder. We found across all substance use disorders, there were 13 studies that met our criteria, 5 of which in alcohol use disorder. None were really fully powered. Many were retrospective cohort studies or single arm prospective studies. Despite those limitations, there were still markers that these were things that patients would be very open to. There were some signs of comparable care therapeutic alliance and retention. And so to me, this explains why the literature pre-COVID, which there was very limited literature, suggests that telehealth for substance use disorder was far less utilized than telemental health. Telemental health is actually the bulk of telehealth delivery in the US. But before the pandemic, you see that telemental health grew tremendously. Telesud care grew a little bit, but far behind telemental health. I do believe there are many gaps. One is actually urine toxicology screens, but a lot of other things are around kind of beliefs. Can I verify someone's telling the truth about their substance use? Those are ongoing things that we found in studies to date. And then obviously came the pandemic, everything changed. I just want to emphasize that there are key policy changes, 2 things. One is allowing us to do phone visits for the very first time. None of us ever thought that would be possible. Obviously, the reimbursement changes. These are things that are currently under debate. I work also a lot in the MOUD literature. There's obvious ongoing debates within the DEA. For alcohol use disorder, we don't have to face those debates because our medications are not controlled. Yet there's still ongoing questions about ongoing reimbursement of phone and video visits. So this really led myself and our team to conduct a series of studies in the VA. Both of the studies I'm presenting are led by a hepatologist, Punny Paramil-Swamy at the Ann Arbor VA. What we looked at was trends in alcohol use disorder care in the VA from 1 year pre-pandemic to 1 year post-pandemic. And what we found was that percentage of patients with alcohol use disorder receiving treatment early at the first start of this time period was only 13.8%, not surprising even in the VA. But unfortunately, what we found was that at the start of the pandemic, there was a dramatic drop, 4.3 absolute percentage points at the start of COVID. And unfortunately, that had not normalized by 1 year post-pandemic. We continue to follow this data. We believe that we'll continue to see gaps in disparity or gaps in care that further increase the gaps that we originally had seen. I want to comment, though, that we conducted similar studies in medications for OUD. We actually saw increased treatment during the same time period. And I can talk a little bit about why there's been this gap. The key reason is when we disaggregated the type of alcohol use disorder treatment delivered and the change in that over time over the last couple of years during the pandemic, what we found was the main contributor was the fact that on the left, alcohol use disorder psychotherapy tanked and never really rebounded, unfortunately. What you'll see is, I know it's not super clear, but overall, the treatment rates dropped and we disaggregated it by telehealth, meaning both video separately from phone visits. And what we found for psychotherapy was that phone visits were not very much utilized. We all know, especially in group psychotherapy, it was really challenging, especially early on in the pandemic. And some clinics really continue to have trouble with that, even though some patients preferred phone visits. In contrast, on the right is actually AUD medication rates. That actually looks very similar to our buprenorphine findings for OUD, whereas medication use actually increased because phone visits actually helped really supplant in-person visits, and then they continue to do so, and I think patients felt comfortable with that. But because psychotherapy treatment far exceeds medication treatment, and potentially for good reasons, we saw an overall drop in care. And so I just looked at trends, but what we also really care about is what is the effectiveness of telehealth for alcohol use disorder? And you can't look at trends over the pandemic because obviously the pandemic happened. So instead, in the second paper that's currently in press at ACER, We looked at the association between receipt of telehealth and treatment utilization, meaning retention on both psychotherapy and medication treatment days. And similarly, Dr. Paramalswamy found that after adjusting for all other patient level differences, receipt of any telehealth, which is actually the vast majority of our patients in the VA in this cohort, that was associated with both increased medication days and also increased number of psychotherapy visits, which is not shocking, but is probably the first time we found that in alcohol use disorder populations. And lastly, in terms of data, it's not just about numbers, it's also about patient experiences. In another study conducted in our team, led by Rachel Gerard, who's currently a grad student or a PhD candidate, we interviewed patients with alcohol use disorder, asking them about their perceptions, experiences with telehealth. And really the endpoint is it's not a one size fits all. Interestingly, patients did describe a number of key benefits they found from telehealth, including stigma reduction. I'm having a harder time reading this because my eyes are not so good at this point, but decreased, I would say that it would be the phone. It sometimes felt better. The actual non-contact is easier because you can't see if they're judging you or not, meaning their therapist. Not to say the therapist was judging, but because of the impact of stigma, some folks really felt like telehealth was associated with reduced stigma. That doesn't mean that patients on the whole preferred telehealth. Really, people wanted choices. And the most important part about that choice was what was their realistic alternative. We had patients who said, I hate telehealth, but it's the only way I can receive care. Other people who said, I love telehealth, but I still want to see you in person. And so that kind of choice, and in a lot of our current settings, it's still like the clinician says, okay, our clinic is able to offer telehealth, you get telehealth. There's still, uncertainty about what a shared decision-making model would mean when it comes to choosing modality of care. In addiction care, there's this long-held underlying belief that patients need to demonstrate they really want it, right? And, I don't know if that's familiar to some folks, but, and there's many reasons behind that. And I'm not saying that's not a helpful approach for some people, but that kind of feeling, I think, still permeates a lot of care, so that this idea of accessible care is still at odds with some of that historical feeling. All right, all of this is still to say that there are ongoing barriers that we need to address. We have found that although almost everybody in the US seem to have some experience with telehealth, Zoom in one way or the other, there's still a lot of clinical uncertainty, especially for substance use disorder treatment. For general mental health, I think telehealth is here to stay at very high levels, for better or for worse. For substance use disorder treatment, due to a lot of logistical barriers, UDS, these perceptions, attitudes, and things like that, it's not clear what things will look like in the future. Lots of logistics and other things. I do want to show this. This is from the 2022 NIAAA, which added these questions about telehealth use among people with substance use disorders. This is not just AUD specific, but across all SUD. And apparently use of telehealth treatment was actually right above inpatient care. That's actually incredible. And actually it's above use of medications for alcohol use disorder treatment. So people have exposure to it, but it's not clear what quality and other things mean. I'm going to just emphasize a few things, which is to really say, I think what I've been emphasizing, it's not just telehealth. It's about changing kind of how we approach care, because you know what, there's going to be bad quality telehealth out there, just like we have poor quality in-person AUD treatment, there's going to be poor quality telehealth care. And so the questions are more broadly, what are the ways that we can engage the 90% of patients who are currently not treatment seeking? How do we need to change the way we think about substance use disorder care, including increasing accessibility, appealingness of treatment? Telehealth might be a part of that, but we probably need other things too. And lastly, I want to give thanks to NIAAA. We currently have the ability to start looking at some newer models of care that we've developed in our healthcare system. I currently co-lead 2 studies with a close colleague, Erin Bonar, who's a clinical psychologist. This is one of the studies, it's called InReach. We're in year 3 of that. And really, it's testing what I would like to call a person-first model of alcohol use disorder treatment. What we do is we proactively screen, identify patients in our healthcare system. We're doing this at Michigan Medicine. We're also starting up at the Ann Arbor VA, using EHR records, ICD-910 codes, looking for people with likely untreated AUD, Then we reach out to them, we contact them, we deliver a motivational intervention to engage them in care. And then most importantly, we offer them care delivered via telehealth. So we talked a lot about ESPR and brief interventions. The thing that's a little bit different about this is we know historically the biggest challenge with ESPR is actually RT, referral to treatment, because a lot of all the barriers that we know exist in community care. So in this model, when a patient says, okay, yeah, I think I'm willing to think about this, we say, okay, let's schedule you for a treatment visit next week. You don't have to make another call. You don't have to show up in person. Let's just get you into care. The other thing I want to really emphasize what we've learned from this, just anecdotally, most patients who we engage this way, they're not engaging in other form of specialty treatment. A lot of them have never been in treatment before because of all the barriers. And the key thing is when we talk to them about treatment goals, almost no one says, my goal is to stop drinking. Most of them say, you know, I've been really depressed lately. I can't sleep. Drinking's the thing that helps me. And we say, okay, let's start there. Let's talk about, you know, all the things that that are going on in your life. How do we help you achieve improvements in those things? And really, what's the role of alcohol and how that plays? And so it's not focused on abstinence. It's not focused on some level of drinking. It's just really focusing on helping patients think about their goals in general and achieving some functional improvements in their lives. Summary and recommendations. I think obviously we've touched a lot about different things. We've never done this in alcoholic liver disease patients, but I don't think the approach is necessarily that different. This idea that yes, no level of drinking is safe, but what does that mean in terms of how we work with patients who are not interested in stopping drinking, which is 90% of people? I think that there's a big chasm that we don't know how to tackle at this point. All right, I'll stop there.
Great. So bringing it all together, we have Dr. Jessica Mellinger. She's a gastroenterologist and assistant professor at the University of Michigan. Her research interests focus on improving clinical outcomes for patients with chronic liver disease, with emphasis on access and care coordination in patients with an ALD.
Yep. That's what.
All right, well, thank you. Thanks for the introduction, Laura, and thanks everyone for showing up. It's a great meeting, lots of really great talks. So I'm going to focus on kind of a potpourri of what I think are some unmet needs, gaps, and opportunities you asked. So I'm going to just tell you what I think about where we have some, interesting ways of moving forward with this. And there are a lot, so I'm just selecting a few that I think could be important, and I'll be really curious. I would love for this to kind of stimulate discussion amongst us about where we all think, we could do better, where we could make some difference here. A few disclosures. So just to kind of situate us, I know Dr. Rasrani is going to give a more thorough talk on the social ecological model of behavior change, but just to acknowledge that when we're talking about behavior change, when we're talking about alcohol use reduction, alcohol use cessation, there are many levels on which we can intervene, and oftentimes interventions have to incorporate multiple levels. A lot of what I do is down at the individual level, but just to kind of keep this in the back of our mind as we go forward through the rest of the conference as well, that a lot of these unmet needs, gaps, and opportunities are going to exist across this spectrum. And so we can start thinking more broadly about how we can do this on multiple levels. So I also just want to orient us again that when we talk about screening and intervention for alcohol use in our ALD population, we have what I like to call early stage versus late stage. So early stage being kind of non-cirrhotic, non-severe acute alcoholic hepatitis. And then later stage being those patients who do have cirrhosis, whether it's compensated, decompensated, or that more severe acute alcoholic hepatitis. Later stage folks, especially if they are decompensated, acute ALCHEP, have very high mortality rates. So I love what Dr. Lin just mentioned about the fact that we need to really be doing better to connect those patients to treatment. Think about what happens when I scope someone and I find a new colorectal cancer. I make phone calls. I get them to the cancer center. I am getting them set up with their CT scan. I am calling and following up and making sure that they got there. And my ALD patients sometimes have higher mortality rates than that person with colorectal cancer. We do not do this well. And we need to be doing much better handoffs to our patient, for our patients, especially in this setting, to get them into AUD care. So I loved hearing that from Allison. But just to think about, when we're in the early stage of disease, which is a lot of what this conference is kind of focusing on, is how can we find these patients earlier? We may see a greater range of alcohol use disorder, a greater range of consumption than we do in those later stage populations, where for me in the ALD clinic, the vast majority of those patients have moderate to severe alcohol use disorder. And a brief intervention is probably not going to do it, for them. They're going to need medications, they're going to need advanced care, IOPs, et cetera. But in that early stage phase, ESPR is more appropriate. We may actually be able to catch some of these people, and then by diagnosing their ALD, which I'll talk about in the next session, is going to go into more detail on, diagnosing that ALD at early stage becomes a leverage point. It becomes a point at which we can say, hey, you have this in early phases. And there is some literature to show that that kind of biofeedback, as was talked about by Dr. Bradley, et cetera, on liver disease, biomarkers, et cetera, can help people reduce their alcohol use. In the early stages, things in the primary care clinic, things in the ED, in the inpatient setting may be a more appropriate place to find it, because early stage ALD is kind of hard to find. And so in the later stages, interventions that are situated in the hepatology and GI clinics may be more appropriate, in addition to primary care, ER, inpatient, et cetera. We like to focus on kind of finding and treating that AUD in the later stages as really, our primary of importance, not the only importance, obviously. And in the early stages, I think our bigger challenge is finding the ALD. How do we find it earlier? So to that approach, I think that probably in the ALD side, they're going to talk about this a little bit, but AI approaches for screening for alcohol use, I think, are very interesting. Again, when I think about trying to look at, population level studies in my healthcare center, in broader systems, how do we find them? It's unstructured data. An alcohol use diagnosis is considered unstructured data. So it's text, right? You get a whole bunch of medical students to go and sit down and comb that record. It's really hard. But what Dr. Fernandez, who spoke earlier, came up with was a natural language processing method of identifying risky alcohol use. And one of her current ongoing NIAAA funded grants is focusing on how to use the same methodology to actually diagnose levels of alcohol use, heavy use, alcohol use disorder, purely by going into the chart and running these NLP algorithms. And what this published information from the early part of that study showed was that NLP was substantially better than just ICD-9 codes, right? Like, I've used ICD-9 codes, I think we all have, but it caught 3 times more risky alcohol use using NLP. So I think more along the lines of this. I am not an AI expert, so I'm going to use words like machine learning and AI and the cloud. And I have no idea, but you know what I mean? Like, somebody with more expertise will talk about exactly how to do this, like Dr. Fernandez. So could we do this for ALD screening? And again, I think our next session, people may be talking about this. There is some literature on later stage disease, alcoholic hepatitis, more advanced ALD, that shows that some of these AI approaches are actually good for prognosticating with alcoholic hepatitis when we already know that they have it. And then also looking at post liver transplant alcohol use for those who've had transplants. But what we really need here is, could we combine an approach like Dr. Fernandez's, NLP, plus some of the structured data approaches for ALD, labs, biomarkers, et cetera, put those two things together to find our early stage ALD patients. These things can crawl imaging records and say steatosis pops up, those path reports, all of that. So we might be replacing our medical students in our training. I'm sorry. The next big gap, I think, which was alluded to, was how do we get individuals to do this? So our GI hepatologist, again, focusing on the alcohol use piece of this, we don't screen a lot. This was a study that Jean M., who's here today, and I did and published on how do providers who take care of ALD patients, this was the population we surveyed, how well do they do at adhering to this guidance, receiving, if they're receiving care, how often are they getting routinely screened? Only 22% actually did this very much, very often. And then how often are we counseling them that there's no safe level and that they should abstain? 60% of the time, so that's good. But often it is like what Dr. Fernandez and others have talked about. You should stop drinking. Bye. See you in 6 months, and not really addressing some of the barriers that they tell us, like the one that I run across a lot. I don't need treatment. They don't think they need it. you know, even if they have moderate to severe AUDs, even if they're in my ALD clinic, they just don't think they need treatment. And we just published a mental models qualitative study that went through some of the reasons why they think they don't need treatment, right? They think they have to want it, right? They think they have to want it. It's all up to them. I got to be 100% willing before I go into treatment. No, you don't. We can work on willingness. You can have 1% willingness. We can build that. So messaging this, understanding why they think they don't need treatment, understanding why they don't want to do this. We can train people to do this. We can train people to offer medication-assisted therapy. Again, the biggest, most common reason why people, GI hepatologists, didn't offer this was because we weren't comfortable with it. We didn't feel like we really knew how to do it. And I would say that's probably triple for how to offer behavioral interventions, right? Like, I don't even think we think of that, right? We just say, we type it in the after visit summary, like, you should stop drinking, you know, find alcohol, bye. So suboptimal. This is, again, something that was mentioned about flipping the script, looking at SBIRT in inpatient settings, but also going into alcohol use disorder clinics, going into the alcohol use disorder world as a liver doctor, and then finding the ALD there. This is data that Jay Luther at Mass Gen has published about his Alive service, and this is a phenomenal name. Mwah, good job, Jay, on your intervention. This is a service where liver hepatologists and hepatology APPs in the inpatient setting go to alcohol use disorder patients who are admitted and then find they don't have diagnoses of ALD, but they find them, they do fibroscans, they do alcohol counseling around an ALD diagnosis. And so what they have found, and they've done several hundred of these, is that pharmacotherapy uptake is increased at discharge, fibrosis testing is increased at discharge, connection to care, both liver and AUD is increased, hepatitis screenings. And so really great proof of concept here from Jay and his team at Mass Gen about how to do this flipping the script. And I think we need more of this. Again, early stage ALD is hard to find. So we're gonna have to go looking for it in all of these different ways if we really wanna bend that curve down long term. So really innovative in two ways, going into the inpatient setting and then improving that MAD uptake and fibrosis through testing people who didn't have ALD and finding it. I would also add to this novel settings, maybe something that we could think about is, again, think broadly. Where else in research have difficult to find populations that are not integrated into the healthcare system, like Dr. Wu's quadrants that we saw, people who are low in care, they're not in the system. How can we find them? And I think of initiatives like the Black Men's Health Initiative that went into barbershops and churches to find people in the Black population who did not typically engage in care, but who had a lot of health conditions, hypertension, prostate cancer, diabetes, et cetera. They went into these really novel areas and it worked. So where else can we, I don't have all the answers for this. That's why it's a question to you. I'm throwing it out there. That's how you do your talks. Just give you guys questions and then we can think about it. Is where else can we go in a novel way to find these patients and get them connected for care instead of waiting for them to come to us? So I also want to think about new ways to screen and intervene. Again, this is Dr. Wu's great study in HepCom from last year. So this is a study that looked at passive sensing, an app that's called the Aware app, downloaded onto the cell phone that connects, oh, so much data. This is all the data that they collected. I won't go into all of it, but it collects a lot of passive sensing data off of the cell phone. We're doing this study at University of Michigan now to look at encephalopathy and alcohol use and some of the differences in what's called your digital phenotype. So it's where are you moving? How often are you connecting to Wi-Fi? What's your typing rate and how accurate and slow or fast is it, right? So you can see that stuff with this. Dr. Wu and her colleagues combined passive data with active ecological momentary assessments that are basically surveys and scales that you push to patients through their cell phone throughout the day to test craving, et cetera. And what they found is that the passive sensing, the sensors did predict some of these different elements of craving, mood, et cetera. And this was in a population of patients who had alcohol liver disease, mostly advanced. Right, Tiffany? Advanced, thank you. Alcoholic hepatitis patients. So a really cool feasibility proof of concept study about, again, how can we efficiently use what our patients are already doing to find out if they need treatment, where are they at with their treatment? Are they having more craving? This is a craving, an inter-individual craving map of bigger triangles mean more craving and how it varies throughout the course of a few days. This is all passive. right? Nope, nobody's sitting in a clinic to get this. It's on their phone. I know I have my phone with me like all the time. I can't get rid of it. I don't want to. That's a whole other issue. But they have it with them all the time. And then you can send them little surveys or not. That's the other cool thing. How much of this could be just totally passive? How much of this can we just see from the sensors and then have it do that work for us so that we don't have to go out and try to get them into clinic and get them here? And then kind of just thinking about public policies, I do think there's a lot of different public policies that we could focus on, that could be just generally more targeted to ALD, particularly around some of the things that were brought up around telehealth, the difficulties with reimbursement, the uncertainties around reimbursement. I have patients who have to drive, they live in Ohio. I'm not licensed in Ohio. They drive across the border to a rest stop, and then they do their video visit with me. And that's because of the way the laws around licensing are structured and telehealth, okay? So these are the kinds of things that I think we could change. There's a lot of options here. Dr. Sengupta and I are publishing a review on alcohol health policies with relation to ALD that goes through more of this to think about how exactly can we do this. Again, social ecological model, those policies on alcohol and ALD may actually be some of the most powerful ways that we bend the population curve down. We need to do it all across the levels, but those are powerful. And then again, I love talking about harm reduction. I just think it's so cool. We do this in ALD, right? Like, so when I'm in the clinic, and all the clinicians here know this, if I have a patient that doesn't want to stop drinking, I am doing harm reduction, right? I'm focusing on what they can do. I do think they should stop, but hey, maybe they don't want to. So we try to, get them to, what they do want to do. But I would point out that when I ask my patient about pain, insomnia, et cetera, as someone else pointed out, and I focus on that, that's harm reduction, right? They don't want to do, they drink because they can't sleep. So we focus on their sleep, and then that brings their alcohol down. So more studies on harm reduction. I would love to see this, that focus more on AUD symptom reduction. How does that impact liver outcomes? How does that impact alcohol outcomes? Kind of thinking a little differently about how we talk about alcohol use, AUD treatment in these patients. And then just purely from a research approach, I would love to see more community-based participatory research in this population. I mean, certainly in some of the qualitative work we and others have done, you get great, incredibly rich information about what patients think. I mean, this is really, talking to my patients in this way has really changed the way that I practice. And CBPR takes us from doing research on a community or a population, even further than doing research in a community and population, to doing it with them. So setting the research goals and the research study structure with your patient population that is advising you. We're doing this in our Integrate trial. Setting up a patient advisory board before we even get the study started to say, what should we focus on? What's important to you? And I think that's really critical as well. And then finally, just another shout out to what kind of research we need. As was mentioned in the last talk, I don't think we need to reinvent the wheel on screening and brief intervention. So we don't really necessarily need efficacy studies unless we've got really truly new novel ways to screen and do brief interventions, absolutely. But a lot of what's been talked about has not really been tested in the ALD population, but could be highly effective. And there are many implementation studies, many types of them, but I do think we need more of these types of implementation studies, particularly implementation and effectiveness trials, and also pragmatic trials. Shout out, Marina. So Dr. Serper is an expert in pragmatic clinical trials. She'll probably talk about some of that with us, but these are trial types, especially with the implementation effectiveness, where you combine, as it says, implementation and effectiveness. So there's 3 different types. Type 1, you're emphasizing a little bit more the effectiveness piece, but you're gathering implementation research. Our Impact ALD R01 is doing this with respect to the CHESS app in alcohol cessation amongst ALD patients. Type 2, you're kind of doing both. You're emphasizing both equally. And then type 3, you are emphasizing the implementation aspects, maybe a little bit more than effectiveness. But this shortens the time from testing to getting it into the clinic. And I think that's what we all want, right? Like what we hear and what we'll hear more throughout the day and tomorrow is that we need more, right? Like we just don't have enough tools for these patients. We don't have enough, that we know definitely works. So these implementation trials, pragmatic clinical trial designs are a great way to go from, we don't have a lot of information to, yeah, we have the information. And now we also know a little bit more about how to implement it. So those are just a smattering of potpourri because you gave me the mic, Laura. So what I think about what might be coming next, I'll be excited to hear what others have to say. Thanks.
We have, so we have some time for questions. I know it's lunchtime on the schedule, but we got a late start. I mean, these were just such fantastic talks. I know folks have questions. So if I could invite the speakers to come on up, we'll bring around another chair.
Okay, great. So I really loved this session. I mean, to see this innovation and really this idea of patient, kind of meeting the patient where they are for their treatment. You know, the first session, we really talked about demographics of kind of the ALD population and how the typical patient is, you know, middle-aged and white. But, you know, I practice in Los Angeles. That's not at all who I'm seeing. You know, I have an ALCAP clinic, and it's really the changing demographic is what we're seeing. So my patient population, it's 85% Spanish speaking. Our average age is 38. It's 30% female. And, you know, I can't help but think is the changing demographics because the models of care, whether it be for screening or treatment, were really developed for, you know, a different demographic. And I'll give an example in that AA, you know, it was developed by white Protestant men in the 1930s. And I can't believe how many women who are my patients who tell me they don't like going to AA, they don't feel safe there, they get hit on. So my question for you with these novel therapies, have you seen any even just screen failures or engagement amongst different demographics, whether it be age, sex, or, you know, race, ethnicity?
We have another R01 that was funded thankfully by NIAAA under our disparities mechanism. And in that study, we are engaging people with untreated alcohol use disorder in a multitude of different e-health interventions. And there we are having enhanced recruitment of both women and also Black African Americans. And we thought really hard about this, and we had proposed it in the grant in terms of quote, like, you know, tailoring kind of materials and things like that. But then the question is like, what does that really mean? Like, are you going to create new treatments and interventions for every subpopulation? In an ideal world, yes. Realistically, probably not. And I think some of this is getting back to what do you truly mean by patient-centered? And I think a lot of us mean different things when we say that. But it does mean, in some circumstances, having specific women-focused groups or Hispanic women-focused groups with Spanish-speaking populations, when you understand that there are really key factors, drinking patterns and things like that. But then in other ways, it also just means asking very specifically about that person's experience, how they feel about their drinking, what's contributing to it and stuff. Obviously, the hard part is we don't have time to ask such patient-centered questions. But I do think that that's what it entails.
This whole idea of, you know, personalized treatment, but generalizability. Amazing, thank you.
I was going to make one more comment to that. Shared decision-making is really kind of the cornerstone of patient-centered care. And it's something that hasn't been integrated into medicine for alcohol use disorder a lot. So that's what we're doing a trial focusing there, starting with and all the different types of peer support. So smart recovery for, you know, the woman. And so there's a decision aid that's on NIAAA's website that we developed with patients where the patients told us, and there's a thing called an option grid where it has, you know, counseling, medications, group-based therapy, peer support, and then it has all the things patients cared about down the side, which is it free? Is it somebody with lived experience? Can I do it from my home? So, you know, does it, you know, all the different things, will it be in my medical record? So anyway, I think framing things with shared decision-making is something we haven't talked about that needs to be on the agenda.
Can I just add really briefly that I think it also speaks to the potential value of these slightly longer brief intervention models, perhaps integrating motivational interviewing where you do have just that little extra time to see what are the patient's priorities, explore a range of options, and then go from there, even though it's more work than your very brief intervention.
I'm so glad you said that. I want to augment that. Most people who don't have alcohol use disorder who are told to stop drinking because they have liver disease will be able to stop drinking. So I want to reframe that. So most of the people with alcohol liver disease who don't stop drinking do have an alcohol use disorder. Brief interventions have never been shown effective in people with alcohol use disorders. So we're really talking about bigger. We're talking about brief intervention because it's not in specialty care, but we really have to think of it as treatment that we move into the medical care, which I think we'd all agree with. And so I just really wanted to highlight that we're really talking about people with alcohol use disorder, or they typically will respond and be able to cut back on their drinking when medically advised, in my experience, and I think based on the disease. So.
A lot of the brief intervention that I'm doing in my liver clinic is really interventions for that RT part of SBIRT to try to get them to go to treatment. So it's the focus of one of our RO1s, the Engage ALD, which is about getting them engaged into treatment because, as you say, they need it. And a brief intervention purely for alcohol cessation just probably isn't going to work.
I just want to mention something really quick. There are a couple people who are going to use their table mics to ask the question at Chris's suggestion. So it's not just the people lined up who want to ask a question. Just Bill and Joe, be aware.
I want to ask the group, I mean, because you said a really key thing about engaging them in treatment. There's no trial that I know of that's ever been shown that referral to treatment is effective. I mean, that, you go here. I mean, and people have looked at it in the brief intervention trials. So I really want to say it's really about, it's what Allison was talking about. It's really about bringing them in and engaging them and figuring out how to engage them either within your clinic or with a partner. Many of us have been trying to get rid of the RT part for a while.
I have a question for Jessica, actually, about this screening for ALD in AUD patients. About 10 years now that I had worked with, this alcohol rehabilitation center in Indianapolis. At the beginning, when I work with them, who is also a psychologist, the hepatic panel is not part of what they do. Eventually they do that. And then we saw like 25% of these patients have AST elevation as one of the slides that you just mentioned. Now, when I look at the FIB-4 score, about 25% of those have FIB-4 more than 2.67. Now, even though that's what I did, the FIB-4 score, but this is not even implemented in the AUD clinics or in that rehabilitation. So from what you just said about this unmet need, how can we do that in terms of incorporate at least some of the non-invasive markers as a signal? And, if they get the score, how can we do better, not educate, but increasing awareness that, there's some simple scoring system, should this be part of the EMR, like Audit C for the VA system? What is your thought on this in order to detect these patients that out there that you said is so hard to detect? But I think there's a lot of people out there that we do not do a good job.
Oh, yeah. I think
for
it's a giant unmet need is, this massive amount of early stage ALD that's floating around out there. It only shows up when it's decompensated, right? Like the scale that we saw. And I think Dr. Thiele will probably mention this in her talk quite a bit about how to screen for ALD in a population. She's done a lot of work in that. But I do think that it is going to be a combination, kind of a range of things, as you've mentioned. The, more hands-off approach of trying to program something like this in EHR. We can do a dot phrase for MELD scores that automatically populates a MELD score. We could certainly do that for FIB-4s. Trying to kind of do something along the lines of what I mentioned about combining these machine learning automatic AI approaches that are scanning and crawling, looking for an ALD diagnosis, and then popping up I know none of us want more best practice alerts, but popping up, I hate to even say that, but popping up yet another alert that just says, hey, this patient might have ALD, here's what you might do, do this X, Y, or Z. But I also think that's not going to be enough. I do think that we are going to have to go into those clinics as clinicians. And I think that was what I wanted to highlight about what Jay Luther did at Mass Gen, because that's that kind of even more integrated, phase of that, yeah, I don't think we can reasonably expect our AUD colleagues, our addiction colleagues to suddenly learn all about hepatology and how to calculate a FIB-4 and, know all of this stuff that as hepatologists, we've spent our whole life, training to do. Similarly, the other way that we do it, is to have addiction people come into the ALD clinic to help us manage these patients. And I do think that needs to be part of what we do. And how that happens, how that integration happens, I think happens on many different levels. And so that's a huge opportunity for us to start thinking about novel ways of doing that at whatever level you can do in your local area, in your local system.
Thanks.
Sorry, I'm interrupting without standing. Gene M, Mount Sinai, New York, wonderful session. I wanted to ask the speakers about their impression about phosphatidylethanol or PEth. I've been thinking about that throughout the first and second session, right? So acceptance from primary care, screening, monitoring, brief intervention. Really, it's the first time maybe in history that we can reliably, accurately follow and verify alcohol use. And yet I haven't really heard anything about PEth, So if you go back 20, 30 years, if you think about PEth as like a fructosamine or a hemoglobin A1C, it wasn't being used for the diagnosis of diabetes. I remember being chided as a resident for thinking that, right? But now it's in all the guidelines and well accepted, right? So I think that though it's expensive and not totally available, but I was reminded in Dr. Bradley's talk about, the audit C question number 3 about binge drinking or heavy use. Essentially, that's a PEth, right? If based on the cutoff. So I'm interested in the panel's thoughts about incorporating PEth in the research and yeah.
Yeah, I can start with that. So for those who aren't familiar, phosphatidylethanol is a blood-based direct alcohol biomarker that produces a PEth value of various ranges that goes from 0 and up to very high, more than 2,000, with some dose dependence in that value. So there is some validation that over 200 nanograms per ml is consistent with heavy drinking. Under 20 is consistent with very low to moderate drinking. Though those validation studies, I will say some of them have been performed in liver disease, some not. There is also one study that I'm aware of that was done in non-ALD, just AUD patients that validated PEth levels against the scale, the audit scale. So showing that higher PEths correlated with heavy use, maybe more problematic use and more towards the AUD symptoms. My own view is that PEth is a very useful tool for detecting alcohol use. And I think that it's important for that. I think and that's how I use it. I think we still are going to have to go beyond that to the alcohol use disorder diagnoses of how this is actually impacting a person. And so I think that PEth, very, very useful in terms of detecting alcohol use, as you say, and maybe we'll get more data that kind of correlates it with severity of an AUD in the future, which would be a great point. And so I certainly use it in my clinical practice. It's a little expensive research-wise right now, so I actually don't use it in my research studies just because it eats up so much of the budget. But I think it's useful, although I don't think it's a panacea. I don't think that we'll be able to say, oh, your PEth is positive, and that tells us everything we need to know about this person, and the complexity of their AUD.
Just wanted to add something to that. As a physician, yes, tests are amazing. I do think PEth is a really nice addition. Putting on my kind of training director hat, the one thing that I think is always still important to remember is what do you do with the results of that test? And one of the things that oftentimes comes up is this gotcha effect. In addiction care, we see it very often. It's the patient lied to me, right? I caught you. And so it creates it. So when we think about ordering that test, we have to think about how do we talk to that patient if the test is quote positive, negative, somewhere in between. If it's an unexpected result, an expected result, even the terms that we use, how do we train our trainees to think about, what's the next step? Those I think are really inherent parts of treating addiction as an illness that are not as typical in other types of medical tests.
Yeah, I agree with that concern.
I'm gonna
and
have
we got to
to-
be careful. I'll just be very brief. Just say
So
to
we
say
have
that
someone waiting in the back, though.
we don't have the same concern about diagnosing diabetes, even though they say they're not eating sugar, right? So.
We have someone who's been waiting in the back so
Okay.
patiently, and I know we're almost at time, but yeah.
Thanks to everyone, and thank you, Dr. Bradley. I'm a big fan. I work in the VA, so I'm Marina Serper from Penn and Philly VA, and I'm so happy that you're here. I have a question about binge drinking versus moderate, heavy ongoing use. You talked about question 3 of the audit C, binge drinking being very informative. Has anyone thought about, if we're doing population-based screening, are there different phenotypes of patients? Should there be different pathways? If you answer yes to question 3, should you have, go through door number A? And if you, qualify for moderate heavy use, door number, B? Has anyone thought about that? Because in my clinical anecdotal experience, these are different groups of patients, and we should maybe talk to them differently.
On a population level, I mean, my head thinks like that too. We have all these populations, we need systems. I think the reason I pause is that the health system that we're talking about out there in this country is very broken. Primary care in particular we are going to be lucky to have a primary care system in a few years. So I think we have to figure out how to screen everybody before I would start worrying about the buckets. Now, I do think we should probably be saying, okay, this person screened this on the audit C and their AST is high. What do the hepatologists want? Because we could easily pull those people, but what's important there is then, does our system have the capacity to treat all those people, which is not a trivial thing. So I think there's a lot of it has to do, and I would keep us close to the ground and affordable. Anyway, that's kind of my bias.
Yeah, I think that's a theme too that I've heard that I hear from what Allison said and others is that, if you're gonna throw the ball, you got to have someone to catch it, right? Like if you're gonna ask the question, we got to know what we're gonna do with it. And I think that's something that
And that's why I wonder, is binge drinking easier, harder? We don't
Yeah.
know.
don't
That's
think
a
we know.
question. Should we know more about this?
Yeah.
That's a question that I have. Should we study this more?
Yeah.
Is it more easily modifiable perhaps?
I think the healthcare workforce has to be trained to be comfortable with this condition. And then many people can be having all those conversations to find out more. I mean, it's on a patient level.
Yeah. I think it would be an interesting study. Like if you could do this at Philly VA, right? Like pull the data, pull that out at 3, see
Yeah.
what happened, look at it and see if there are different outcomes. I mean, that's almost like a perfect latent class analysis, study. Is this a phenotype here different?
So I wish we could keep going. But we do need to stop. Yeah, because folks need lunch.
Yeah, let's try to come back at 1, try to catch up the schedule. And anybody need guidance where how to get to the uptown? And there are 2 other choices.
Back from lunch. Please take your seats. It's 8 after 1. I think we are going to go ahead and get started. I am Svetlana Rodaeva. I am from NIAAA, and I will be starting off session 3 of the workshop. Our session will focus on very interesting but yet very challenging topic titled Breaking Barrier to Early Detection of Alcohol-Associated Liver Disease, Identifying at-risk individuals for disease prevention. First, I would like to introduce my co-chair, Dr. Samit Ashrani. Yeah, he's the chief of hepatology and liver transplantation, director of hepatology research at Baylor University Medical Center. He will guide us through the late part of the session. To set the stage for our session, here is the outline of the program, and you can see we will have 4 excellent speakers. They will cover broad spectrum of topics from current state to future trends, including global efforts and personalized approaches to disease prevention. So, and with that, it's my great pleasure to introduce our first speaker, Dr. Maya Thiel. Dr. Maya Thiel is a professor of hepatology at Odense University Hospital and University of Southern Denmark. Her research focuses on management of early stages ALD, including development and validation of biomarkers. Dr. Thiel is a contributor to international guidelines on non-invasive fibrosis tests, She is a member of the Bovina Consortium Research Committee and work package leader for a randomized trial on screening for liver fibrosis in 10,000 patients, which will be conducted by the newly established European Liver AIM Consortium. Dr. Maria Thiel will be talking about global efforts on early detection for ALD, lesson from Europe. So, yes.
Maybe I could start saying that we will actually do a randomized study in 100,000 patients and not 10,000. So we're even more ambitious, no problem. And I hope maybe to have a little time in the end to discuss this exciting opportunity for actually showing if screening works or not. These are my conflicts of interest and funding. I'm heavily funded by the European Union, who've launched several programs on screening, the latest one being the Liver AIM project, where we will do a randomized study. So I have three main topics for my talk. I want to talk a little bit, we already touched upon it, on who should we test when it comes to early detection of alcohol-related liver disease, how to do the testing, and what have we learned from referral pathways, especially in Europe. Initially, it was Europe and Asia, but for alcohol-related liver disease, not much has been done in Asia, to my knowledge, at least. So if any one of you have insights from Asian screening studies, please approach me. I would be very eager to hear. We discussed the harmful effects of alcohol and the risk for liver disease. And I think it's important to acknowledge that even what we may call moderate intake of alcohol is harmful for the liver for a proportion of patients. So I know the recent nomenclature change with MASLD, MED-ALD, and ALD uses around 2 units per day for females and 3 units per day for males to distinguish between MASLD and MED-ALD. However, and again, the NIAAA, you have a quite high level or threshold for at-risk drinking. But when you look at the data, we really need to consider that alcohol can impact the liver even for those drinking a rather small amount of alcohol. So this is data from a meta-analysis of 24 studies looking at development of cirrhosis. And it's pretty small here, but you can see just from 20 grams of alcohol on average per day, the relative risk is already more than 3 times for females, and it's even already elevated 1.60 relative risk for males. So already on average 2 units per day, there's an increased risk of cirrhosis development. And another meta-analysis looked at drinks per day. So one drink can be different from country to country. In Denmark, it's 12 grams. I believe, is it in Japan? It's 20 grams as a unit of alcohol. So it varies quite a bit. But anyway, in this study, this is occasional drinkers, not too much increased risk, but already at 1 unit per day, especially in the studies investigating females, there's a clearly increased risk of cirrhosis development. So I think the primary target population for screening for ALD should be at-risk drinking, and we can define that just by daily drinking. The follow-up is quite different in these studies included in meta-analysis. So for me, a key question is, for how long should this drinking have been going on? I've been looking a bit into the cohorts we have in Odense, and we don't really see a clear signal when we look at the length of excess drinking. Even those reporting only 1 year of excess drinking may have moderate or severe fibrosis. So The question is whether you can really trust people's self-assessment of the lengths of drinking. The second part we can consider for a target population is incidental finding of steatotic liver disease, because it seems like when you find steatosis in the liver, then a large proportion would be related to alcohol or a combination of alcohol and metabolic dysfunction. This is an Asian study looking, I think it was a South Korean population, in people coming from for a primary healthcare check, so fully unselected population. 8.3% of the population had steatotic liver disease and at-risk drinking. So that would be your med-ALD, ALD population that can be targeted for subsequent fibrosis screening. And this is MRE results from the same cohort. And you can see those who did report a high level of drinking, putting them in the ALD category, had on average a higher mean liver stiffness than those who had steatotic liver disease purely because of ALD. So the final target population could be those with elevated liver enzymes, and we already heard nice presentations about we should suspect AUD and ALD when detecting a patient with an incidental finding of elevated liver enzymes, especially AST. However, it's very important that AST has a high specificity for ALD and AUD, but a very low sensitivity. So if you go out into the population, you will see the majority of people with ALD having normal AST levels. It will be rare, and this is data from the FinRisk cohort, so again, a population-based study. And you can see even those who belong to the kind of the highest drinking group in the population, the majority will have normal GGT, normal ALT, both for men and women. So if we find transaminase, elevated transaminases, we should definitely screen for alcohol use disorder and alcohol-related liver disease. However, we can't use this as the only criteria for selection. So for the sake of time, I won't go into the evidence behind which non-invasive tests have been validated in alcohol-related liver disease. So this is just purely a list, and you'll have to trust me that there are studies out there showing their discriminative accuracy for detection of advanced fibrosis and cirrhosis. The non-commercial blood-based markers, I have a few slides on the CLIF-D study, which is Frederik Åberg, my Finnish colleagues' risk assessment tool, not really a fibrosis test. And then the liver risk score was published last August by the Liver Screen Consortium, which is a multi-European screening consortium that I'm part of. The ELF test is something we can measure in clinical practice in Denmark, and I believe you can in the US as well. However, I don't know how it is with reimbursement. ProC3 may be coming on a Roche platform, so that is something that could in the future be measured in clinical care. And FibroTest is a French company, Biopredictive, that I believe also can be measured in the US. It may be called FibroSure, but you may know more about this. Imaging is something we use in secondary and tertiary care. Ultrasound or MRI elastography. MRI elastography hasn't really been validated in an ALD, but I would assume that it has a high discriminatory accuracy, similar to other liver diseases. The issue here is if we are talking about early detection, we are talking about primary care. That's my firm belief, or at least settings outside of a hepatology specialist unit. So the elastography measures are really, in my view, too expensive and not implementable for a wider scale screening, and I won't go into them anymore. So the next obvious question is, how to do it? And I think what we have today is we are really missing a fecal occult blood test or a mammography similar to cancer screening. We do not have a screening test that is as accurate as what we see in the cancer screening programs. So what we need to do is to have a two-step strategy. Step one, we should use a highly sensitive test that can rule out the majority of those screens. And then subsequently, in those screening positive with the first test, we then apply a highly specific test to rule in. This way, we will avoid all those false positives. And the issue is that FIP4 is not really very specific. So this is just a dot plot of the FIP4 values on the y-axis and elastography values on the x-axis in a pre-liver screen cohort of, was it 8,000 Europeans, all at risk. So 80% of the dots you see here have at-risk drinking from France, UK, and Denmark. And it's pretty clear that you see this is the threshold 1.3 for FIP4. And there's a lot of people who fall into the category of low FIP4 and low liver stiffness measurement below 8 kilopascal. However, all of these, which is around 50% of the full population, have a positive FIP4 above 1.30, but a normal liver stiffness. So FIP4 results in a lot of positive tests in at-risk populations especially, which if we implemented FIP4 as the only screening test for ALD would mean that we would be overwhelmed by referrals. And this is simply not feasible, likely also not cost beneficial. FIP4 also has some false negatives, these ones out there, but it's a small amount of patients that we overlook, likely the young ones, because FIP4 of course contains age. Now, sequential testing we have tested in my unit in Odense in Denmark. So we did a study looking at FIP4 only, ELF only, or a sequential test using FIP4 first, and then a confirmatory ELF in those with indeterminate FIP4 results. So FIP4 between 1.30 and 2.67. And this is the results if you stratify patients only using FIP4. What we did was using transient elastography as the kind of the reference value. So we didn't biopsy all, of course. And here you can see, so around a little more than half of the participants at risk of ALD had a negative FIP4 test, but around half, a little less than half, had a positive FIP4. So a very high rate of positive tests. And this bar shows how many of the positive tests were false positive, meaning they had liver stiffness well below 8 kilopascal, and how many were true positive with liver stiffness above 8 kilopascal. So we do detect patients with FIP4 only, but we will need to, there's a large group of pure noise or false positives. If we use the ELF only, we get a far higher percentage of true negatives. So we can already say to 3/4 of patients that they have normal ELF tests, not to worry about their liver. However, we do have some more false negatives. So the orange one is all of those participants with a liver stiffness above 12 kilopascal, so indicating quite strongly that this is a patient with potential liver fibrosis. So that's an issue with using the ELF only. However, the proportion of true positives that could in principle be referred further was much higher than with the FIP4. So finally, this is the data then for the sequential testing using FIP4 first and then ELF. I'm sorry, I put it the other way around here. And again, we see that more than 3 out of 4 was true negative, and we have a high proportion of true positives in those referred further for screening. We do still see 5% false negatives, but few of them have very severe liver disease. So I think this, for now, at least until we have one screening test only with a high sensitivity and high specificity, this is a doable option for early detection of liver disease. I promised a few words on the liver risk score because this score was developed in the liver screen cohort of kind of 9,000 participants, general population screening, so no selection on ALD or MASLD or anything, to detect liver stiffness. But then it was validated for liver-related outcomes in the UK Biobank of more than 400,000 patients or people. And the liver risk score stratifies patients into low risk, medium, and high risk. And this is the overall liver-related mortality in the UK Biobank, again, not selected on alcohol use. But what I think is interesting is that those with high-risk liver risk scores have the highest risk of liver-related mortality, liver-related hospitalizations, and HCC, while the non-liver-related mortality is also increasing, but not as much. So it seems to be a liver-specific test. And when you look into the appendix of the study, there's a nice overview of how the test performs in those who report daily drinking in the UK Biobank. This is the top graph here. And you can see these three risk strata is really good at differentiating those at the highest risk of progressing to liver-related outcomes versus those at the lowest risk of progressing to liver-related outcomes, while in the non-drinkers, liver risk score really doesn't perform very well. Same with occasional drinkers. So it seems like the liver risk score should be, in principle, at least until we validate it, a very good risk stratification tool for those with daily drinking. These are the hazard ratios also from the UK Biobank, and you can see how those with daily drinking and a high liver risk score has a hazard ratio of 390 for developing liver-related outcomes. Finally, a quick overview. It will be some busy slides, but I hope we can take them one by one on those studies that have investigated early liver disease detection in people who consume alcohol. So if we start in the general population, there has been a small US study in the NHANES cohort, but other than that, it's primarily been European studies. So we need to acknowledge that US and Europe are different populations. There may be differences. Most of these studies use transient elastography. And again, I think for implementation purposes, this will be really difficult to do in a primary care or general population setting because the equipment is simply too expensive to purchase. So at least in Denmark, we pay 200,000 euros. I don't know how much that is in US dollar for just one machine. And it can only do liver stiffness measurement. It doesn't really do anything else. So I think we need to take these data and then transport them to a setting where we do blood-based detection. However, I think it's interesting to look at those with positive results, so liver stiffness is above 8 kilopascal. It's around the same in the Odense population as it is in the NHANES cohort, although the cohorts are different in size. But at least more than 10% of those with at-risk drinking will have a positive liver stiffness measurement. If we go to primary care, there's different studies, most of them in the UK, a single in Barcelona and Spain. Again, different sizes, not impressive when you compare to the MASLD field. Most of them using liver stiffness to risk stratify and finding somewhat similar rates of positive testing. I think we can safely say that if you go to general population or primary care and looking at the alcohol cohorts, you'll find more than 10% cases, or you should be able to find more than 10% cases. If you find less, there may be a problem. Then the final kind of setting for testing has been through referral pathways, again, UK-based, and finally addiction units where we would expect the disease prevalence to be much higher. And indeed, we see positive cases in 20 to 30% of the participants in those settings. There's also been 3 studies looking at not detecting advanced fibrosis or cirrhosis, but rather concerning risk stratification, so more prognostic studies, which I believe is what has a true interest to patients. They basically may not care whether they have fibrosis tissue in their liver, but they may really care whether they are about to become hospitalized with decompensation, whether they will die from a liver-related event. So the liver-related events has a true meaning for patients. And this CLIF-D score is based on the FINRISK cohort of 25,000 individuals in Finland, and they had a bunch of lifestyle questionnaires, including for alcohol. And indeed, when you combine everything into a collective risk stratification score, not looking at blood-based testing, but rather looking at waist circumference, for example, smoking, gender, age, and alcohol in drinks per week, then the CLIF-D score could quite accurately risk stratify patients even before blood-based testing. I mentioned the liver risk score, which was validated in the UK Biobank with outcomes. And finally, we have a small population in Odense in Denmark of 241 patients from primary care, mostly from addiction units with a liver biopsy, but also with outcomes. And in this study, we tested both transient elastography, ELF, PRO-C3, and FIB-4, and they were all predictive of outcomes. The highest prognostic accuracy was for transient elastography, but ELF and PRO-C3 came very close by. FIB-4, not so much. So finally, I just want to mention that what we could do when it comes to detection of ALD is to use the pre-existing cancer screening programs or annual healthcare checks or anything that brings a patient to a screening center or primary care facility or anywhere outside the hospital where you would anyway do a global risk assessment. So this figure just shows which variables goes into risk targeted lung cancer screening, which is something that is about to be implemented in at least some European countries. Obviously, smoking here comes in and a lung cancer family, but it would be fairly easy to combine such a questionnaire that should anyway be delivered to a large population with questions on alcohol, for example, the Audit C, and some rough questions, for example, some of those questions that go into the CLIF-D score from the FINRISK cohort. And then you could have both a risk assessment for lung cancer, deciding whether the patient goes into low-dose radiation CT, and a risk score for liver disease that decides whether the patient is referred for transient elastography. And this is how it looks, the CLIF-D score, again, as a kind of pre-screening risk stratification tool, because I agree with the previous speakers that we need some systematic, automated, non-stigmatizing way of risk stratifying patients. It's not good enough to ask the individual GP or GP nurse to simply ask the patient. We need to automate the risk stratification if we want to reach a broad population of those with harmful use of alcohol. So I would propose to evaluate at-risk drinking in all healthcare systems, but I think for systematic screening programs, primary care is the place to be. And then you can do opportunistic testing in primary care when the patient anyway comes, for example, for other targeted screening programs, or if you have an annual health check, which many primary care patients has. And we have several different options for blood-based testing and risk stratification, and then referral to a confirmatory elastography. There is some discussion about ongoing drinking and doing especially transient elastography, whether you get false high values in those with inflammatory activity in the liver, evidenced by elevated AST, elevated GGT, elevated bilirubin. It makes sense to repeat the testing after a period of either reduced drinking or abstinence, but I never refrain from doing an elastography investigation regardless of whether the patient drinks alcohol or not, because oftentimes we can use, we can always use a negative screening test. So if they have a liver stiffness below 8 kilopascal, regardless of drinking, I trust that one. But also the elevated ones seem to be prognostic. And in those studies that have tested whether it's alcohol in itself or inflammatory activity that causes an increase in elastography, then with abstinence period, the liver stiffness decreases in parallel with AST and bilirubin levels. So it seems like it's not the alcohol per se, it's rather the steatohepatitis that causes liver stiffness to go up. So again, I always do the liver stiffness regardless of drinking, but then if I have doubt, I ask for a new one after 1 to 2 months. So my final recommendations, we should consider non-invasive testing for liver fibrosis in patients who report at-risk drinking, and we should put the level for at-risk drinking at rather low thresholds. So low that it would be MASLD for some of the patients, according to the new nomenclature. If we find steatotic liver disease or elevated liver enzymes, this should trigger alcohol history or AUD screening. And since steatohepatitis correlates with elevated non-invasive fibrosis tests, not just elastography, but other tests based on transaminases, then consider repeating the test for confirmation after abstinence or reduced drinking. And finally, we recommend FIB4. And in line with the previous comment about screening for AUD, it's better to do any screening than not screen. So I'm not an opponent of FIB4. I just think as a community, we need to work towards replacing FIB4 with something that has a similar sensitivity, but a higher specificity because of the false positives. And in the meanwhile, we can consider a sequential pathway. So my final, if I hopefully have time, I'll tell you a little bit about the Liver AIM study. So it's a European funded consortium that will do a randomized trial in 100,000 Europeans from the general population. So not specifically on alcohol, it will be all types of MASLD, med-ALD, and ALD. But what we will do is we will randomize either to screening or to standard of care, and then we will wait 10 years and we'll see if the screening actually results in reduced liver-related mortality and liver-related hospitalizations. And I think this is the key to actually show that screening works, because we need to show a benefit for the patient. We cannot live with just detecting the disease earlier and then it will be overdiagnosis and lead time bias if we don't actually do something to the natural history after detecting the disease. And with that, end my talk. Thank you so much.
So our next speaker is Dr. Brian Lee. So Dr. Brian Lee is a transplant hepatologist at University of South California. He's a physician scientist with NIAAA funding. with research that focuses on cofactors of liver progression in ALD, especially obesity and genetic risk factors. His research program also focuses on public health policy and early liver transplantation for ALD. He will be talking on current state strategies for identification of at-risk individuals for ALD detection and progression in the US.
Okay, well, I'd like to thank the organizers for, really preparing this workshop. It's been really fantastic to hear all these talks. And I'm looking forward to telling you a little bit about, sorry, the presentation disappeared here. There's your monitor. Okay, so how I frame this talk is really to talk about epidemiology and natural history of ALD, really in the context of how to identify your at-risk population. And then, I've hoped that I can convince you that ALD has many cofactors for disease progression, but at least to think about it in the context of at least a trifecta of disease, that will need at least a three-pronged approach to effectively screen for ALD. And I'll go through the screening strategies one by one for alcohol use, metabolic risk factors, and liver disease. And then finally end with future directions. So we'll start with the patient case, and this is a patient who I've seen. So this is a 28-year-old woman who's Hispanic who presented to primary care to establish care. She endorsed drinking, quote unquote, only socially. She had routine blood tests, which were normal, and she was advised to return to clinic in 2 years. 2 years later, she returned for routine follow-up. She was found to have elevated liver enzymes. She endorsed that she had been stressed with her children and increased from half a bottle of wine per day on weekends to 1 bottle per wine on weekends. She had an ultrasound which showed just fatty liver, and she was advised to quote unquote, quote, cut down on alcohol. She was advised to return to clinic in 6 months. 6 months later, she developed jaundice encephalopathy. She was admitted to our hospital, diagnosed with ALCHEP. Her MELD score is 35. She did not respond to medical treatments and underwent early liver transplantation. We've all seen some variation of this patient, and this is important. Globally, ALD is now the #1 cause of cirrhosis. It accounts for 48% of liver-related deaths in the US and 50% worldwide. ALD cirrhosis hospitalizations account for $23 billion per year in healthcare costs, and ALCHEP accounts for 1% of all US hospital admissions, which is a 26% increase in the last 8 years. And recently, liver disease has now become the #1 cause of all alcohol-related deaths. So ALCHEP represents a disproportionate burden to public health compared to its prevalence. It accounts for 18% of all alcohol-related hospitalizations in the US. Median age is declining, and it's increasing amongst young adults. It's increasing more amongst females than males, and it's increasing across all races and ethnicities. The results has been particularly pronounced since the pandemic. Multiple studies show that increased stress is associated with increased substance use as a coping mechanism. Between 2019 and 2020, there was a 34% increase in national sales of alcohol, a 22% increase in ALD-related mortality, and these increases were most pronounced amongst young adults. On the right figure, you see the US transplants for ALD that we published. It appears that these increases are sustained. Transplants for ALD continues to rise and now accounts for 43% of all liver transplants in the country. So if we think about the pathophysiology of ALD, it really starts on the left side. With chronic alcohol use, over 90% will develop steatosis, 20% will develop fibrosis, 8 to 20% will develop cirrhosis, and some will develop liver cancer. ALCHEP is associated with the fastest disease progression. There's a dose-dependent risk. For every unit per day increase of alcohol ingested, there's a 17% increase risk of liver steatosis. Cofactors include age, female sex, metabolic risk factors, smoking, comorbid liver disease like Hep C, and genetic polymorphisms, of which PNPLA3 is the most commonly studied. So if we think about whether our patient is at risk, I like to think about it about these three important categories, which is heavy alcohol use, metabolic risk, and factors for liver disease itself. So for our patient, for heavy alcohol use, she had young age and anxiety, and she was female. These are risk factors that we're currently worrying more and more about in the contemporary landscape of heavy alcohol use. Metabolic risk factors, she was obese. And in terms of liver disease, she was Hispanic and endorsed several family members with fatty liver. This raises question whether she has a PNPLA3 mutation. So I would say these would all be red flags that she's an at-risk population for liver disease, for ALD. So if we go one by one, we'll start with screening for alcohol use. So the US Preventative Task Force has a 2018 update, which states that it recommends screening for unhealthy alcohol use in primary care settings in adults 18 years or older and providing persons engaged in risky or hazardous alcohol drinking with brief behavioral counseling interventions to reduce unhealthy alcohol use. However, despite this recommendation, there's a national survey from the National Ambulatory Medical Care Survey of over 19,000 primary care visits, which found that only 2% of visits, including alcohol screening, with a validated survey. There's higher likelihood of using a validated survey if it was a new patient or if they were seen by their assigned primary care doctor. There's no difference by patient sex, age, race, ethnicity, or time length of the primary care visit. So, I won't embarrass myself in front of Dr. Bradley by talking about the Audit C, but, this is the most commonly used validated survey. And we know in the VA setting that it is feasible to use this in a large scale. So in the VA's primary care setting, it is mandatory on an annual basis, and they've shown more than 90% complete documentation. Talked about the NIAAA single alcohol screening question. It has about a 70% sensitivity and a 90% specificity to detect unhealthy alcohol use and/or alcohol use disorder. So we'll hear from Kaiser Permanente about the alcohol as a vital sign, which they've incorporated since 2013. But in 2019, they reported an 87% screening rate in primary care. And the prevalence of alcohol use exceeding the NIAAA threshold for heavy drinking was actually 13%, which is high in this primary care setting. So we need to acknowledge that these surveys really depend on patient self-report. And it's possible that there is covert alcohol use. So how I define covert alcohol use is either negative self-report in the setting of actual alcohol use or underreporting of alcohol use. So for example, Gene and his team published that only 65% of transplant for ALD candidates with a positive alcohol biomarker, PEth in this case, self-reported alcohol use at their baseline visit. There are intentional reasons for covert alcohol use, such as shame, stigma, or fear of negative clinical consequences, such as disqualification for transplant. There are also unintentional reasons for covert alcohol use, like recall bias or misunderstanding as to what constitutes one standard drink. So you can see on the bottom left is what we describe as a one standard drink. And on the right, you can see based on country, it ranges from 20 grams in Austria to really 8 grams in the United Kingdom. In the US, it's 14 grams per standard drink. It's also important to acknowledge that not all patients with ALD have alcohol use disorder. So harmful alcohol use without addiction is highly prevalent and actually normalized in our current society. The prevalence of alcohol use disorder in a large cohort study amongst ALD cirrhosis was reported to be only 38%. We've seen this meta-analysis of 7 cohort studies with over 2 million adults, but it showed that the risk of cirrhosis increases amongst women with any alcohol use, more than 1 drink per day amongst men. And former drinkers had a more than 3-fold higher risk of cirrhosis than lifelong abstainers. So this, when you have a single time point of Audit C, the question is whether you're really capturing historical alcohol use. So the take-home message here is that we need to screen for all levels of alcohol use, past and present. What about metabolic risk factors? So this is the new definition, new nomenclature. So there's a newly defined subpopulation of ALD, metabolic dysfunction associated steatotic liver disease with increased alcohol consumption, MET-ALD for short. So on the left side, you have MASLD, which is less than 20 grams for women and less than 30 grams per day of alcohol for men. On the far right side, you have ALD, which is more than 50 grams and more than 60 grams for men per day. In the middle, you have met ALD. So this is data published from Maya's group in Denmark. But in the red line, you have time without hepatic decompensation. These are patients without steatotic liver disease. In green, you have MASLD. In blue, you have met ALD. And in purple, you have ALD. This shows that met ALD and ALD are distinct from MASLD and have worse outcomes. So the take-home message here is that met ALD is a new subpopulation that needs specific study for appropriate screening strategies. We have to also acknowledge that we don't really know what the true drivers of the ALD mortality surge were. So on the left, you have on the y-axis ALD deaths per capita, and on the x-axis, you have year. ALD mortality was actually stable before 2006, but since 2007, there's been a steady increase. On the right figure, you have the prevalence of alcohol use disorder. You can see that there was actually a stable or declining prevalence of alcohol use disorder and alcohol use between 2002 and 2018. So we don't fully understand why ALD mortality surged because it wasn't necessarily correlated with alcohol use rates. So we looked at this question, and as a reminder, metabolic syndrome refers to 3 or more of 5 obesity-related factors: waist circumference, triglycerides, cholesterol, and high glucose. We used the NHANES registry between 2015 and 2018, and we found that risk of advanced liver disease, if you had metabolic syndrome, was 3%. If you're a heavy drinker, 5%. But if you had both metabolic syndrome and you're a heavy drinker, it was 11%. We then found that the national prevalence of metabolic syndrome increased from 28% in 1999 to 37% in 2018, but actually the prevalence of heavy drinking was stable. So the conclusions here were that metabolic syndrome synergizes with alcohol to cause liver disease, that increasing metabolic syndrome may be contributing to rising ALD prevalence and morbidity and mortality. So this is going to be increasingly relevant. So if this is published in the New England Journal, and in 1990 and 2010, this represents the prevalence of obesity by state. In 2030, it's projected that the US prevalence of obesity will be 49%. It will be over 50% in 29 states, and no state will have an obesity prevalence under 35%. The highest increases are projected amongst women, racial and ethnic minorities, and lower household income, which makes us concerned for increasing disparities that we're already seeing in ALD. So this is another study that we published looking at the prevalence of metabolic syndrome amongst heavy drinkers. So you can see that the proportion of heavy drinkers with metabolic syndrome is increasing over time. This is a study that we published looking at the national prevalence of steatotic liver disease and its subcategories. On the right side, you see that the met ALD prevalence is actually higher than ALD. And over 99% of patients with ALD had one or more metabolic risk factor, meaning that metabolic risk is really universal amongst patients with ALD. So the conclusion here is that there's really unmet need for optimal screening strategies for metabolic risk factors among individuals with alcohol use. So we'll now move on to screening for at-risk liver disease specifically. So liver fibrosis is really what we're looking for. It's the strongest predictor of mortality in ALD. So this was a European biopsy proven cohort, and they compared patients with fibrosis 0 to 2 versus advanced fibrosis, which was defined as fibrosis stage 3 or 4. In multivariable analysis, fibrosis stage 3 or 4 was associated with a more than 16-fold higher risk of mortality compared to those without advanced fibrosis. Despite ALD fibrosis occurring over a long period of time, so 7 of 16% of heavy drinkers will develop cirrhosis only after 8 to 12 years. We've seen this figure before. They're rarely detected early. So this study showed that advanced liver disease was defined as liver decompensation or liver cancer. And ALD was uniquely found at late stages compared to other etiologies of liver disease. So there are missed opportunities for liver disease screening. Over half of patients diagnosed with ALD have had a healthcare contact for alcohol without being screened for liver fibrosis. Abnormal liver enzymes are a very common reason for referral to a specialist, but not an effective screening tool. So for example, abnormal ALT only has an accuracy of 48%, a sensitivity of 10% to identify advanced fibrosis. The first line screening test as recommended by guidelines are FIB4. It requires no extra testing. There's high negative predictive value, but there is mediocre positive predictive value, as Maya explained. However, despite this recommendation as a first-line test for screening, in a primary care survey at UCSF, while 75% of physicians were knowledgeable about the importance of liver fibrosis, only 15% reported using FIB4. After FIB4, it's recommended to pursue a confirmatory test due to the positive predictive value, which is only mediocre, with transient elastography and ALF tests, which are additional tests but have high positive predictive value. So these are the ASLD screening guidelines for at-risk liver disease and MASLD. Essentially, a primary care physician checks FIB4, and based on this score, there are recommendations for transient elastography and ALF testing and reasons for a specialist referral. So there are very few data looking at population level screening in the US, but this is an example, at least in the MASLD realm. So this was in a closed healthcare system by Zobair Yonossi in over 7,000 patients in the Inova Health System through an electronic health record of primary care and endocrinology clinics. Over 1,700 met inclusion criteria based on their diabetes or metabolic risk factors. 700 agreed to enroll and had non-invasive tests calculated from blood tests routinely ordered in primary care. 184 had 2 or more non-invasive tests that were positive and invited to be referred to a hepatologist. Only about half of these patients actually agreed to be referred. 66% had hepatic steatosis, and 8% had liver stiffness that was compatible with advanced fibrosis, which is defined as over 12 kilopascals in this study. So putting this back together, how do we bring this back to our clinic? So if we look at our very first patient, this 28-year-old woman who presented to established care who endorsed drinking only socially, what if she underwent an alternate path? What if she underwent screening with the Audit C and it was found to be high? What if she had her metabolic risk factors assessed and she had her FIB4 calculated, which was high? She was counseled to stop drinking. She was referred to a comprehensive weight loss program. So she was referred to hepatology with transient elastography and ALF testing showing advanced liver fibrosis. She stopped drinking, she lost weight, she followed regularly with her health team. And over years, her transient elastography suggested actual regression of her liver fibrosis. Obviously, this is an ideal situation, but I think it is possible. So, where can we move in the future? I could talk forever about this, but these are some ideas, I think, to really enhance ALD screening. Reducing stigma, normalizing alcohol discussion so that you're able to detect alcohol, increasing use of alcohol biomarkers like phosphatidylethanol to detect covert alcohol use, improve screening tests for metabolic risk factors and liver fibrosis that have higher positive predictive value, artificial intelligence to identify at-risk individuals based on already pre-existing available data that you don't have to order more tests. This would automatically quantify the ALD risk by incorporating, for example, your alcohol surveys, metabolic risk factors, lab values, cofactors. I'm very interested in genetics in the future. We're not there yet, but imagine if you had genetic profiling on all your patients. And then finally, this really has to be automated. A doctor can only do so much. So really, I think the goal is that whatever kind of decision-making tool, it really gives you a yes, no, whether the patient needs any further testing or referrals. Okay, this would really maximize your case ascertainment with the fewest false positives. And then I think, improved treatments are important. A patient, it takes a lot of activation energy to see a doctor. It takes a lot of cost. A patient is not willing to see a doctor if they don't think that the doctor has something that will help them, something to offer them. So if you have more effective treatments for alcohol use disorder, for metabolic risk factors, for ALD-related hepatitis and fibrosis, I think this incentivizes patients to get screened because there is something at the end of the tunnel. Okay, it also optimizes cost effectiveness of your screening strategies if you have cost-effective treatments. So, I really think that any strategy needs to maximize the impact to a broad population. So, I started with one patient who had ALCEP, who underwent early transplant. There are 500 early transplants for ALCEP in the country per year, but most don't make it to transplant. There are 3,000 deaths for ALCEP per year. There are 30,000 deaths for ALD per year. And in the US, there are 13 million adults with ALD who might never see a doctor. So, how do you engage at-risk individuals who are not yet linked to healthcare? This is kind of a whole other topic probably, but, I think mass education, public education campaigns, when and how to see your doctor, why to see your doctor, educate the public about alcohol, metabolic risks, and liver disease, and reduce stigma to normalize these discussions amongst the public. Increase community partnerships, and then, finally, tailored programs personalized for high-risk populations that we're seeing. So in conclusion, screening for ALD needs to consider current and historical alcohol use in the context of cofactors, and I'm particularly interested in metabolic risk. ALD can occur at alcohol levels lower than the NIAAA heavy use threshold, and I think something to think about is whether the NIAAA should change their definition, because this is important for messaging. Met ALD is the predominant and growing form of ALD and is a subpopulation that will need further study now that it has a uniform definition. ALD trends in the US are concerning for increasing sex, race, socioeconomic-based disparities, and research amongst US cohorts are needed to design optimal screening strategies that should be a public health priority. And finally, effective screening strategies need to consider individuals who are not yet well connected to healthcare. Thank you.
Thank you, Brian, for great talk. So now I would like to invite Dr. Marina Sörper. Yeah, Dr. Marina Sörper is from University of Pennsylvania. She is broadly interested in health outcome in liver disease and liver transplantation. She and her team perform prospective patient-oriented research on factors to improve health, as well as conduct retrospective analysis using large database. She will be talking on inclusivity in healthcare, tailored approaches to ALD screening in diverse rural and underrepresented communities. So please, Marina.
Okay, thank you so much for having me. I'm going to try to entertain you here in this later afternoon. I am going to probably reinforce a lot of the themes that were talked about because they're broadly applicable to more vulnerable populations. And I've changed my title a little bit to talk about policy and care delivery approaches. So we're not going to spend too much talking about the burden, but we will think about a little bit of the denominator that we see in clinic. Then we're going to zoom out, take an 80,000-foot view on vulnerable communities, rural communities, look at potential solutions. No easy solutions, but really we'll try to brainstorm together. And some of my slides are going to be data-free, hopefully, give you a little bit of a break. And then we'll think about what we can do as a community to make a little bit of an impact. So everybody seems to have different versions of their denominator slides and little people, right, that are affected by liver disease. So I was thinking about my denominator. So if I think about 100 people with at-risk alcohol use disorder, more than 2 drinks per day in women, more than 3 in men, then, out of 100 of those people, maybe up to 30% of them will have significant enough fibrosis that could progress. And out of those people, just a smaller handful will develop cirrhosis and some will go directly onto alcohol-associated hepatitis. But obviously underneath that is a much larger denominator. We all have different numbers that we're reporting. But according to a recent SAMHSA survey, 30 million people ages 12 and over have alcohol use disorder. This includes 12-year-olds, and this is about 25 million adults age 18 and older. And so we're really settling on this number of about 10%, 10 to 13% have alcohol use disorder. And if I crunch the numbers, that's at least 5 million people in the US that I should be worried about. I think Brian had a number that was higher. I saw a number that was lower, 1.3 million people with alcohol liver disease. We don't really know, but I think it's higher than what we think. I think it's far higher than what we think once you see some of these maps. We're going to go through a lot of maps because I do a lot of work in epidemiology. Just as a thought exercise, we're talking about vulnerable groups a little bit. So let's look at the US population density. So the areas that are lighter have lower population density. Let's look at this map now that's showing us people with no high school diploma or GED. Does this correlate with the population density? Very much so. Almost, you know, not perfectly, but very much of an overlay. And what about people in deep poverty? So similar. So there are large swaths of the country, if we're thinking about population health, that don't have high enough education, live in poverty, and they don't have access to healthcare. And there are common themes that have been elucidated in rural communities in terms of risk factors for harmful alcohol use compared to urban communities. Mostly these patients are male, have family instability, low education, and the common themes here of harmful alcohol use are early in the evening and drinking at your home, and also drunk driving, which is very, very prevalent. And it's very interesting when people are asked about drivers of alcohol use in rural communities. It's what my family does. Someone else talked about this theme. Their social norms. You have to drink a lot at sporting events. Drunk driving is completely accepted, especially in rural communities. No one's going to pull you over. And then there are also cycles of binging, abstinence, and guilt, but also feeling socially isolated from your family and friends during those cycles of abstinence. So it's very challenging, and I don't deal with this population at all. So this is more just from my reading and learning. So this is challenging, and I don't know how we're going to solve these issues, but this is what we have to think about. I was also asked to talk about beyond rural communities. What are some other vulnerable groups for alcohol-associated liver disease? And unfortunately, it's pretty much everyone, I hate to tell you. So we looked at a lot of studies. We wrote a paper that looked at social determinants of health and disparities in liver disease. And we had an alcohol section. So who is affected by alcohol consumption? Well, low income, but also higher income people. Low education, but also higher levels of education. It just depends on what type of alcohol you drink. And this is the unfortunate truth. Also Hispanic men. Definitely a population in the United States that needs to be focused on, and various reasons here. There are social norms, there are societal norms, but also PNPLA3. Also have to say that Hispanic Americans are not a monolith. There are different cultural practices, so we do have to do better at getting disaggregated data. But this is definitely a vulnerable group. And also you've heard from others that women are a group that where alcohol consumption is on the rise. Who has problems with access to care? I'm going to show you that it's everyone, okay? But also people who identify as Black, women, those with alcohol-associated hepatitis, those on Medicaid, and those with low levels of social support. Where are the disparities in mortality? It's actually very difficult to tease this apart. It depends on which cohort you use, which study, which population. But we see disproportionate mortality for the same level of alcohol use among women and American Indian, Pacific Islanders, and especially women. So a lot of potential groups to target. We can, it's easier if you work in the community with this population, but these are the groups that we need to be aware of. When we think about treatment barriers, I like to think of alcohol use disorder treatment barriers first and foremost before people get to the liver clinic. So there's an excellent, very comprehensive SAMHSA survey that was conducted in 2020. This was among people who met criteria for needing treatment, who thought they needed treatment, and what were the reasons for not getting treatment in the past year. So here are the themes. So cost is a major theme. Thought it would cost too much, no insurance coverage, health insurance would not pay enough, too high of a copay, could not find where to go or no openings, even if you had insurance and could afford it. Convenience was a factor, so problems with childcare, transportation. We're worried about privacy and what others should say. You know, mental health treatment, there's a lot of stigma and there's a lot of mistrust. And also there are some other very difficult barriers. They're not ready to start. They might be kept in treatment against their will and did not think treatment would help. So really, I kind of summarize these as cost, access, and the way I group that is not enough providers, no convenient times, no transportation, but also very difficult issues such as stigma, accurate or inaccurate beliefs, because we know that AUD treatment is not high quality everywhere, right? Or SUD treatment. And also, of course, readiness. Patients, someone else had mentioned this today, patients feel like they need to be ready, 100% ready to be completely abstinent before they engage. And that's simply not true. So I was thinking about access and I did a little exercise. There's an excellent resources on NIAAA website. I said, okay, I live in Philadelphia. I would like to go to treatment. So there are 111 places for me to go to 5 miles away. And if I want telehealth, still 48 places. And what if I want medication? Sure. And if I'm Spanish speaking and Medicaid, then it starts to really drop off. And this obviously makes sense, right? But this is Philadelphia, which is an urban, densely populated area. What if I go to Branson, Missouri, and I look at treatment within 40 miles away? And let's say I have some barriers where I only have Medicaid and this program has to take my insurance. And let's say I work strange hours and I need telemedicine or I don't have a car. And I really am seeking medical treatment. Well, I only have 3 options and I don't know how long it would take me to get it, right? So this is just a very practical exercise. And this is part of the problem that we're all facing, that everyone actually could face barriers to treatment. So don't really have solutions, but we should be talking a little bit about structural barriers as policy and perhaps intervention targets. So large scale interventions. So we could think about insufficient resources, stigmatizing policies, and workforce shortages are a few of the things that come to mind, particular to alcohol use disorder. And again, I'm focusing my talk really, again, at the 80,000 foot view. This is before or during advanced liver disease developing, but really, I like to think of this as getting to the underlying cause, which is alcohol. So a lot of experts thought that the Affordable Care Act that expanded Medicaid would actually do a lot to help with alcohol use disorder and substance use disorder treatment. So this is an interesting study that evaluated insurance benefits among health plans post ACA on the insurance plan that would on the exchanges. And so it's a little bit of a busy map, but this is for all substance use disorder. And so the number of SUD treatment services covered goes from 0 to 7. So red is 7. So the darker, the more services are covered. You can see there are some states where on the exchange, there are no services covered. And Dr. Asrani lives in this very large state, 0 SUD services, okay? And so you can then also disaggregate this into the individual service, outpatient, intensive, inpatient, detox. So you can see that the proportion of required services covered is at most 70%, but for most modalities is 50% or less. And in terms of medications, if we look at oral naltrexone or injectable naltrexone, 16%, 12% is required to be covered. So this is kind of the current state. So we have a lot of work to do. Something else I discovered in my reading and started going to the legal literature, I was wondering why treatment is not covered by all insurers. And there's a history here. So there are these alcohol exclusion laws, and I don't know if anyone knows about these, but these are in existence since the 50s. And this was supposed to disincentivize alcohol high-risk behavior. This is, for example, if you crashed your car and you had multiple injuries, and this was related to alcohol, your insurance did not have to pay for medical treatment. And so some states have repealed these exclusion laws, but some states insurers actually have adopted these similar types of policies towards access to AUD, SUD treatment. And my state actually permits these exclusion laws. And so there are a lot of states that in the dark green that still have these. And unintended consequences, per my reading, is that clinicians who know about these laws will not necessarily ask, or they will ask but not document alcohol use disorder, let's say, in the ED and the trauma bay, so that the patient's medical bill is not part of their responsibility. So this is a very tangible area, again, for policy, so something to think about. And researchers have looked at what happened to treatment referrals post-prohibition. So Colorado and Illinois basically phased out these laws in about 2007, 2008. And so in Colorado, interestingly, referrals for alcohol treatment went up, but then dropped way down. But in Illinois, they persistently stayed high. So it's definitely not the entire story, but it could be part of it. Another issue, of course, that's an elephant in the room is the addiction workforce shortages. There's a lot of turnover. We know, for example, that licensed clinical social workers who work in SUD or AUD get paid significantly less than those that work in other areas. And so it's very difficult to retain this workforce. And so we are facing a shortage in behavioral health professionals. This is in addiction and psychiatry and also social work. And so what are some of the barriers? So in substance use disorder, and alcohol is rolled into this, there's a 32% turnover rate compared to a 7% physician turnover rate generally. 50% of behavioral health providers experience burnout and lower reimbursement. So not easy problems to tackle, but we need to be aware. Now I'm going to shift a little bit and talk about what we could do for vulnerable populations. You've heard some of this before, and it's not all specific to these populations, but just showing a couple of examples. So we heard about telemedicine, and telemedicine has obviously risen significantly during the pandemic, but we also need to think about telemedicine as being able to offer different modalities. So you can do live video telemedicine, you could do asynchronous telemedicine, you can supervise a provider, a social worker, addiction specialist. So there are different modalities that you can implement and be creative about it. Of course, reimbursement is an issue. And then I wanted to highlight what we did at Penn, again, zooming into our specific patient population, which is the Total Recovery Program, the brainchild of Dr. Bob Weinreib. So basically, we, again, I told you we were going to do 80,000-foot view and back to our clinic. We developed a virtual program that is specific to our patients with alcohol use disorder and advanced liver disease around the transplant episode of care. This is a program that is not based on AA and is not based on 12 steps. And it uses, Bob can explain to you what are the underpinnings of the program, but it's basically 12 weeks and it's totally virtual. It is covered by insurance except out-of-state Medicaid, so it's not fully covered, but we've had very good success with this program. Mini study, not 100,000 people, 42. 32 of them completed our program. Out of the people who completed the program, 22% relapsed versus 80% who did not complete the program relapsed. So I don't know how to get people into treatment, but if they're in treatment, then it will be effective. The other very interesting thing, trauma or PTSD is something that is very difficult to tackle. It was present in 70% of our patients who did not complete the program. So we need to have some trauma-informed care that we integrate. And I don't think we figured that out. And then relapse after transplant was much lower, even though not statistically significant, but tiny numbers, much lower in program completers. We also talk about biomarkers. So here's the two groups and the PEth values. I'm just highlighting that there's a lot more zero PEths in the treatment completion group. So we are showing some early success. I do want to mention, of course, that we're talking about vulnerable people, and we're talking about telemedicine. Those who are older and those who have limited English proficiency and what we think traditionally is underrepresented groups, Black and Hispanic, have less access to smartphones and technology. And I do want to show you this more maps, but a really cool study that looked at liver disease mortality, concentration of specialists, and basically internet quality. And it's what you would expect. So here's where we are. So first of all, 70% of counties in the United States don't have a GI physician, and 41% of people live greater than 100 miles from a transplant center. And the concentration of GI specialists is, of course, lower among people with a higher liver-related mortality. And then the areas here that you see in red on the left, people who don't have access to specialists also have less access to technology. So these are the doubly vulnerable, I would say. Are there any policies underfoot to improve internet access? So there has been $75 billion appropriated to actually do programs from the USDA. But if you can see again on this map, the little green areas are vulnerable areas for having poor technology access, and the little red dots are the ones that have had the pilots happen. So there's still a lot that we need to do and a big mismatch. I actually think broadband internet probably should be an insurance benefit, to be honest with you, in this day and age. So something we could think about. Also want to finish with a couple more models. So here's the ECHO model of care. It's not a live telemedicine model, but here you have asynchronous, where you have a specialist team. This could be addiction specialty, psychiatry, teaching, primary care, frontline providers to deliver evidence-based care. We should be doing this more with alcohol. This is an example of a substance use disorder ECHO program with Utah. Basically, providers can sign up. They can present cases, they can hear didactics, and you can scale knowledge and best practices. And I think the ECHO program, you should look it up if you're not familiar with it, is a model that should be tested. I'm going to finish up with showing again, zooming in on our advanced patients, the tip of the iceberg, our co-located model of care, because I think integrated care, co-located care could make a difference. So we have developed ILEARN Clinic, which stands for Integrated Liver Transplant Engagement and Recovery Network. We're a team that co-treats alcohol use disorder and advanced liver disease before and after transplant. Why is this tied to transplant? Because that's where the resources are. So we do what we can. Who's on our team? We have 3 psychiatrists, 2 attendings, 1 APP, Dr. Goswami and Dr. Weinreep, who are here, 4 hepatologists and 2 social workers. We do 2 half-day sessions a week. We do, what we do is we basically have taken these patients out of our colleagues' medical practice, and we are responsible for them fully. So I think that we're practicing ambush, psychiatry probably, where we get them, it doesn't say alcohol, it says ILEARN. They don't know what they're going to learn. And here comes, psychiatry and addiction medicine. I think another important aspect here is we have an in-clinic huddle where we discuss cases with each other. And here's our team, and we're very collaborative, and everyone feels happier and more engaged, taking care of a very difficult patient population because you do not feel like you're alone. Our principles are multidisciplinary care, no judgment, collegiality, support, respect, communication, teamwork. I think it works pretty well. And we take advanced patients before and after transplant. And the hepatologist's role, which we're still trying to figure out, is really mostly to reinforce what psychiatry is saying while managing the medical complications or just managing healthy post-transplant patients. And so we'll see what happens with this clinic. We're all learning from each other. We're all taking a lot of notes today that we'll bring back to our clinic. The other important thing that Dr. Lee talked about was education. This is an important role that we have. I think we do have to educate the public and primary care. And I think the way that we can do this is with kind of flashy, well-designed, and also multicultural, literacy appropriate messaging. And I don't know if you want to put this in a bus or if you want to put it in a bar, but there's a lot that we can do. So in summary, we have a lot of challenges. A lot of people talked about multi-pronged solutions, and Dr. Mellinger talked about conceptual frameworks. So I think we have a lot of work to do, all the way from the individual level to the health policy level. And I'm just going to leave you with this quote: only a crisis, actual or perceived, produces real change. I think we're at a crisis here. And when that crisis occurs, the actions that are taken depend on the ideas that are lying around. So I think we have a lot of great ideas lying around, and thank you so much for having me.
This was great. So thank you, Dr. Serper. So now it's my great pleasure to introduce our next speaker, Michael Lucy. Dr. Michael Lucy is a professor of medicine and chief of the Division of Gastroenterology and Hepatology at the University of Wisconsin School of Medicine and Public Health. His research interests include selection for and outcome of liver transplantation, alcohol-associated liver disease, and management of end-stage liver disease. So he will be talking on powering health through integration, looking into the future. So please, doctor.
So thank you very much, Svetlana, for that introduction. One slight change. I have stepped down as chief of the Division of Gastroenterology and Hepatology. It's the reason why I look so well. I just want that. Any of you who have the opportunity to make that change, I recommend it. And I wanted to thank VJ, Joe, Sumit, and all the organizers for the invitation and for giving me the title of the talk that I'm giving. And so under the broad title of Reducing Alcohol-Associated Liver Disease Through Early Screening and Management in the General Population, I've been asked to look at empowering health through integration, looking into the future. And that did cause me to have to work out what am I meant to be talking about, which is a little bit challenging. No, it's not the right slide. Let's see. My slides are slightly different order than I expected. That's okay. So let's start with looking into the future. Looking at the future is a challenging thing to do. But I have three models of it here for you. On the far left there, you have Cassandra. You can see her hair flowing in the breeze. That's showing that she's gone crazy. And she was the daughter of King Priam and Queen Hecuba of Troy. And she was given by Apollo the gift of telling the future. And then she resisted him, and he added a curse, which was that no one would believe her. So that's the first problem of telling the future, is that you might have the ability to tell the future, but no one will believe you. In the middle, I've got Nostradamus. That's where you tell the future in such an ambiguous form that it could mean anything. And so you're always right, and you've never really told anything. And the third model I have here is much more recent. This is Phil Connors, the weatherman from Pittsburgh, who goes to Punxsutawney for Groundhog Day. And he foretells that there's going to be good weather. And as you can see, he is wrong. So the other thing is you can foretell the future and you can be wrong. But I'm going to go to a different classical reference, one from Roman mythology. That is the god Janus, the god of entrances and new beginnings. It's from which we get January. But when Janus is depicted, it's usually in this mask form, looking forward and looking back. So in order to look to the future, I think it is necessary to look to the back, look to see what's gone, and to ask ourselves, what do we mean by empowering health through integration? So the first thing I'm just going to show you is a definition of health. What is health? So this is what the World Health Organization considers health to be. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So this is the first integration that I'd like you to think about. It's when we're thinking of the health of our patients, the integrating physical, mental, and social well-being. And much of this has already been touched on. And you will see everything I'm going to say today has really been said by somebody else, and probably better. But in the notion of the mental well-being of patients, because many patients with alcohol use disorder or health problems related to excessive drinking have other problems of mental health as well. And we should not try to forget those or ignore them. We're not going to succeed if we do. Similarly, the social well-being, it's brought out just now in the presentation by Marina, but in many of our presentations, that we cannot divorce the patient's health from the social circumstances in which they exist. So that's the first integration. The second thing I just want to point out is that alcohol use disorder is a disruption of physical, mental, and social well-being. And that alcohol-associated liver disease is the end organ manifestation of excessive consumption of alcohol. Improving the health of patients with ALD will be accomplished by addressing this physical, mental, and social integration to correct or improve their excessive drinking. So now I'm meant to be looking at the future, so I'm going to ask you to accept a series of things that I'm not even going to put up data for. In fact, you're actually going to see I have no data. That's you know, this is a data-free presentation. So the first is I'd like you to accept that there is a screening test for alcohol use disorder. It's been talked about already, and we're just going to accept that AUDIT-C is an acceptable screening test. And I'd like you to accept that there are treatments that improve the health of patients with AUD. And believe it or not, that's worth stating. It's certainly worth stating in audiences other than this, where there's a very widespread belief that there is no treatment that works for alcohol use disorder. The common belief, you often said in these sort of pejorative terms, once an alcoholic, always an alcoholic. They never stop drinking. You know, that view is pervasive among the patients, their families, and the providers who care for them. So we're going to say, no, there are treatments that improve the health of these patients. And then I'm going to say something that's already been pointed out, that patients with alcohol use disorder and patients with alcohol-associated liver disease have many points of contact with healthcare professionals. And I put healthcare professionals because one of the things that occurred to me, I said not anything I can say has not been mentioned already, but one thing that hasn't been mentioned is the transfer of the predominant providers of care in the general practice, at least in the environment I live in, from MDs and DOs to nurse practitioners and physician assistants. And so it's nurse practitioners and physician assistants who are out in these rural areas that were being shown to you by Marina, but also in urban areas as well. They are the first point of contact for many patients presenting to urgent care, to the emergency rooms, where we heard from at the very beginning from Dr. Koop how urgent care is really the front line of alcohol-related mental and physical illness. And finally, then I'm going to say something that waiting to treat alcohol use disorder until patients have overt liver disease is a missed opportunity. I don't think anyone is going to challenge that. So looking back, I decided I better know about screening. Actually, I was trying to find a paper. It's a very common phenomenon for me. I can remember having read something and I wonder where it was. I think it was in the Lancet when I was a medical student on rules of screening. I haven't found it. It's out there. But this is what I found. This paper from 1961, and it attracted my attention because Google Scholars said it's been cited over 6,000 times. So it has to be good. I mean, I think we've got that endorsement. And it then quoted this conference from 1951. So this is to put screening into context. Screening is not new. It's 75 years old at least. So, and it said, what is screening? It's the presumptive identification of unrecognized disease or defect by the application of tests, examinations, or other procedures which can be applied rapidly. So first of all, we're screening people we don't recognize to have the disease. That's the first thing. And the screening tests then sort two groups. There are people who appear not to be unwell. They appear to be perfectly well. And one group probably has the disease and the other group probably doesn't have the disease. And then the group that probably has the disease, you'd like to further research and make the diagnosis and get them the treatment. And the same paper then gave some criteria for evaluating a screening test: validity, reliability, yield, cost, acceptance, and follow-up services. And many of these things have already been mentioned in slightly other ways today already, but I still think they're a very nice set of 6 criteria. So I'm picking Audit C as a screening test, as a model, and it also fits into my belief that we are too late in recognizing the impact of alcohol on patients' livers, and we need to be finding it sooner. So, but it's also, it's the model screening test I'm using. You could substitute FibroScan if you wanted to and say, how does it stack up in the same sort of consideration? And I'm going to say that I think Audit C is valid, reliable, and has yield. So I'm not even going to challenge that. And it's simple to administer, and it can be used over and over again. However, it tends not to be used in primary care or in selected populations such as liver clinics, right? Or when it is used, it tends not to be linked with brief intervention or referral to treatment. So it exists either as a concept not being used, or when it's exercised, it doesn't have any consequences. And so why is that? So we're now going to try to empower screening for excessive drinking through integration, keeping my theme from what I was given. And I'm going to suggest to you that in order to succeed, we have to keep 3 constituencies in mind and have to work on integrating those 3. And they are providers, patients, and health systems. And unless our solutions look at these 3, we're likely to fail to meet the potential of whatever intervention or improvement, or in this case, screening test, we're looking to introduce. So let's again use Audit C here. And I gave you 6 things, and the 3 that I didn't mention were cost, acceptance, and follow-up services. And I think you can bundle the reasons for the less than successful application of Audit C in the community, either in the general community or in specialized clinics, under these 3 headlines. And we're going to look at those 3 constituencies: providers, patients, and systems. And I'm going to do that in just 2 or 3 more slides. And I've just conjured this out of my head, but it's interesting, much of what has been said today fulfills what I was thinking. So why do providers not use Audit C? And so here I've got to be careful, because I'm not a primary care provider. We had a primary care provider speak at the beginning today. I have to say that I am the son of a primary care provider. So at least if my mother were here, she might, she'd probably tell me I don't know what I'm talking about. You know, so it's never always quick at home to be told you're talking through your whatever part of your body. But anyway, providers. So why do providers not use it? Well, the first, I think, was brought out very clearly is competition for the provider's time and attention. It just is one more thing to do when you're have to pack it into a very limited time. And it's not just the provider's time and attention to ask 3 questions. I mean, it can be asked before you get in. It can be on your tablet. What are you going to do with the answers? If you're going to ask the question, you need to do something about it, or else it just sits there on Epic as just another tab that isn't opened. And then there's the question, do the providers accept that it's their appropriate responsibility to ask this? So among the healthcare context, we talked about the growth of alcohol use disorder among young women. So young women going for an annual gynecological exam, that's a point of care. They could have been asked about their alcohol use there, and if they're not. But I suspect if we were to ask gynecologists, they would say, that's not my job. Somebody else should be asking them about that. It's not. So it's we have to find the providers and have acceptance that that's an appropriate care and interest for them. And then they have to feel competent with the answers. And we heard earlier about the paper Jean and Jessica wrote based on the special interest group from the ASLD on hepatologists' views of their role in managing AUD. And they generally feel they don't have the competence, they haven't been trained, they don't actually refer. They just admitted they didn't refer. It's an interesting paper to read. And then there's the beliefs of providers on the effectiveness of interventions. I mentioned earlier that we were going to start by saying we believe there are treatments that work, because many providers don't believe that. And so that's an educational gap. They just don't think it works. And then we've heard a lot about the availability of treatment services. So if the services aren't there, it's not going to work. So that's the providers. Then patients. How many times have you heard patients say, I was told to cut down, but not to stop? How many times? I mean, there's an interesting study from Birmingham in England where they looked at post-transplant patients who had been transplanted for alcohol-related liver disease, and many of the patients could not recall being told not to drink alcohol. Now, they've had a liver transplant, and you say, that can't possibly be. So there's hearing and heeding in this. And then there's the patient's acceptance that alcohol use is relevant for the discussion of that particular provider that day. I've come to get my knee replaced. I didn't come to hear about alcohol. So if they don't want to hear it, they're not going to hear it. And then there's the patient's willingness to accept treatment. Bob and I did a study when I was at Penn, and we compared patients who were recruited for alcohol treatment services and those who are in the liver transplant clinic. And the people in the liver transplant clinic didn't believe they needed treatment. They felt they were past that. Part of it is they didn't want to be thinking of it, but it was the quite different views. Then there's the question of, do patients actually believe that the treatment works? And we heard about availability and expense. Expense, I think, is quite important. And finally, there are systems. The competition for the provider's time and attention is a systems issue. The system can provide the time for the provider to ask the question and find out the answer, or have the question asked in an automated way. And then the system can try to provide availability, integration of services, and support for those treatments through medical insurance. And Marina's points about the way that happens state to state is very important. So a systems approach is, I think, quite important. And all of these things come under stigma. And you can see that stigma can be at the level of the provider, the patient, the system. All can be working in stigmatic ways, often reinforcing the stigma one to another. Now, I want this to be an uplifting talk. I mean, it's been a bit of a downer, I know. So this is the Arboretum at the University of Wisconsin in Madison, Wisconsin. I took this in about the first or second week of the COVID pandemic, but it's almost the same week. It's just like, I was there on Sunday, it's just like this. Now you can see the magnolias are just coming into bloom. So spring is here. We're going to look forward to the future. Everything is going to get better. So everything will be better with. What will it be better with? So these are the solutions that are being offered. The electronic medical records, of course, like Madison, home of Epic, you know. Yes, it's my personal responsibility that you're all using it. And anyone who wants to break out now and go and answer, they're in basket. You're free to leave. So, but we've had electronic medical records for years. There's been an integrated national electronic medical record at the VA for years. And so just having an electronic medical record will not of itself create a better system unless it is linked to patients, providers, and system. But maybe that's not the right answer. What about smartphones? Smartphones are going to fix this. And Jessica mentioned a smartphone study. It's being done by Michigan and Wisconsin, supported by the NIAAA. So I'm in favor of smartphones, but will it work on its own? And of course, I couldn't leave out AI. I thought for a while I was going to be the only person to mention AI. I have to mention AI today because AI has prepared my slides. These are all from ChatGPT, which all of these things are potential benefits to create a better world, but of themselves, they're not going to work, in my opinion, unless we integrate them across patients, providers, and systems. We have to look at that's where integration is meaningful. So I'm just going to give you some ideas of what that might mean. So with regard to providers, it's education. And I mentioned nurse practitioners and physician's assistants. So the education must be at many levels. Nurses, the nurses who are in the clinic, they must be given the same opportunity to learn about alcohol use disorder as the doctors and the other care providers. And this needs to start at medical school and at training, and it needs to be reinforced, but it's a long process. It's not a single process. And then clarified responsibility. I mean, I don't know the right answer, but probably there are some clinical interactions where it's just not appropriate for this, for the screening of alcohol use. But we should actually work out where we want this to be asked and then provide the resources to make it happen. Countering stigma, that goes along with education. One I like is incentives. We could pay the primary care physician to ask the questions and follow up. And, you know, that might work. Pay them, give them some money. So when they've gone through the questions and made sure that there's a process to follow up, they get some more money in their pocket. That would be, I think, a small but innovative response. With regard to patients, I put 3 things in here: encouragement, optimism, and consistency. I think that's terribly important. I think we don't transmit an optimistic view about the treatment of alcohol use disorder to our patients. You know, it's not just, you should give up the drinking, give it up. It's, you should give up the drinking. We know you're not going to give it up the drinking. You know, that's the way it is. It's completely gloomy because we're not really convinced ourselves, and we're not. So we've got to be encouraging of patients. We're much more encouraging about smoking, for example, but not about alcohol. So encouragement, optimism, and consistency. There is a problem with consistency with regard to the liver patients, and that is, are we trying to get them to stop drinking or cut down drinking? And the truth is both. We'd like them to stop, but if they can't stop, we'd like them to drink less, knowing that we're still hoping that they will stop. But it does make it more difficult to give that sort of nuanced, what is the outcome we want. So I think we've got to work on our consistency. This needs to be ongoing rather than intermittent. And we heard a lot about culturally appropriate care. So this, in different cultures, the way alcohol is treated is different, but the simplest cultural sensitivity would be to have it in the right language. And then finally, systems. Resources is the key. This was the first point brought out by Vijay, which I think he said, resource-restricted environment that we live in. There is no return on investment for this. And indeed, the benefit of this, the benefit of taking Brian's patient and saving her from a liver transplant in 5 years' time is not going to benefit this health system. By 5 years' time, she's probably insured by a different health system. You've just taken a burden off somebody else at your own expense. It can only be done in a commutarian manner, but resources are necessary, insurance coverage for treatment is necessary, and integration of care pathways is necessary. So that's where I will end. I think we're asked to give a final slide that as you can see here, this is sailing in Lake Mendota in the capital in Madison behind there. My final statement is that we can empower health through integration by working at 3 forms of integration. That's mental, physical, and social health in 3 constituents: patients, providers, and health systems. Thank you very much.
Thank you so much for excellent talk, Dr. Lucy. So now we are moving on to the discussion session, right?
Right? Yeah.
Yeah, actually, while we're waiting, sorry, yeah, let's go with questions. Thank you.
Something you want to say?
We'll show a couple of things.
Yeah.